Hi, Rashmi.
Good
Thank
evening,
you, everybody.
Good evening, respected ma'am.
Hi, Tripti.
Hi, ma'am.
Hi, Binal. Sweetie.
Binal ma'am.
Good evening.
Rachana.
Binal ma'am. Hello.
Good evening, ma'am. Yes, Monica.
Rashmi.
So I have sent links to Parisar and Madhuri ma'am, but all of them are in Figo. So in the meantime, we will start a program. If they join back, we can take their comments in between.
Yes. We have our chief guest, Pushpa madam is there,
Yes.
so I think we can.
Yeah, we will start. It is already 6:01. Let the delegates link be active, Abhishek, and
yes, ma'am.
start the recording so that we can start the program.
We are live now. So, good evening all. Good evening, all respected faculties and all the delegates who have joined. So, I welcome you all for the Core Connect live webinar on episode 17, which is an initiative by Public Awareness Committee Fogsi in association with Indian Menopause Society. So, I once again welcome you all for the land lightning and beginning of the event.
Abhishek, please mute everyone, and so that we can have the blessings of Lord Almighty, and we will start with the program. I welcome everyone to the 17th episode of the Public Awareness Committee webinars. This is in association with the Indian Menopause Society. We are focusing on the theme of menopause in the month of October, because we will be celebrating the Menopause Day on the 18th of October. We started celebrating this day in the year 2015, and we will be very happy if we could host pink ribbons on that day to spread awareness that menopause is a transition which is very, very, very normal. We are thankful to the presidents, Pushpa Sethi madam and Pai sir, for allowing us to conduct this webinar under the banners of the IMS and TAC. And we are also thankful to Pai sir to give us a theme of amalgamation and ekikaran, where all the organizations work jointly towards one cause. Thank you so much, sir. Abhishek, can we have the e-lighting for this, please? The audio is not heard.
Thank you all. So,
thank you. Can we just have Dr. Binal Shah's slide first?
Yes, ma'am.
I take privilege in introducing Dr. Priyanka Roy as the chairperson of the Public Awareness Committee Foxy, and Dr. Binal Shah madam as the in charge and chairperson of Public Awareness Committee IMS. It is through their joint efforts that we are seeing this webinar. We welcome you, ma'am. She is the national chairperson of the IMS Club 35 plus. He is also a consultant and laparoscopic surgeon. She holds a diploma in gynae endoscopy surgery.
Thank you, Monica.
Yes. Ma'am, I request you to please welcome all our faculties and delegates so that we can move ahead with the program after.
Yeah, sure. A very good evening to one and all, and welcome to this evening, which is going to be very enlightening. And it is only not the awareness for the patients or the clients, as we call them, but also doctors. Because as the science advances, there is a lot of advancement in how we can tackle disease process, because there is a paradigm shift in the healthcare system. Previously, we used to do only palliative. Then came the era of curative, and now we are thinking of preventive. And yes, I'm very happy that today the public awareness committees of Fogsi, the Federation of Obs and Gynec Societies of India, and Indian Menopause Society, we have joined hands together, and that makes us much stronger to tackle this disease, that is osteoporosis. So this month we have dedicated to awareness of osteoporosis, menopause, and breast cancer. And these are the things which are, really having a lot of impact on morbidity and mortality of females world over. So on this auspicious occasion, I welcome the President of Indian Menopause Society. May I have her CV, please, Dr. Pushpa Shetty, ma'am. She is really an epitome of beauty and grace, and she really heads our entire Indian Menopause Society Association with utmost, you can say that, she's so graceful, and at the same time, she's a person whom you can follow in her ideas and her, you can say, grace. Welcome, Pushpa Shetty, ma'am. She is a consultant gynec from Gurgaon. She is the president of Indian Menopause Society 23-24. She has received Lifetime Achievement Award. She has been awarded by the Haryana government for her free breast cancer clinics and a lot of social work which she is doing. And she really brings a lot of joy, and at the same time, a lot of insight into the subject which she touches. So welcome, ma'am, and please give your blessings to the webinar.
Thank you so much, Beenal. And at the outset, a very, very good evening to everybody present here, all my friends. Parag, hi, how are you? So nice to see you on this platform. And everyone here are my past senior presidents, Dr. Ambuja, Sudha Sharma, and everyone from my menopausal circle and from the Fogsi circle. I cannot forget my own days as a chairperson, Midlife Management Committee, Fogsi. And at that time, we did not have that much, awareness or the foresight to do combined programs or projects with the IMS. But I'm extremely happy that, Beenal, you have taken up this cause. And because you are working for the same goal, for the same aim. And it was just natural that both of you should, collaborate to do joint programs. So that is one thing I have to, I'm really happy about, and I congratulate you. And Beenal is doing excellent work even on our platform as a chairperson, Public Awareness Committee. And, this topic that you have taken up, how sensitive I am to this topic of osteoporosis, because, when I knew that I would be president, I was just focused on one thing, that I want every person, every member of the Indian Menopause Society to have clear ideas about osteoporosis, not to see that day that when a person, the lady, you are the first point of contact for the lady who is suffering from osteoporosis, and you just tell her to go to an orthopedician. That is what we were always doing. But no, it's not like that. It's not so difficult to treat that person because she has come to you with all the faith. So I wanted to, bring clear ideas, clarity in mind to all my IMS members about osteoporosis, and number two, MHT. Use of MHT. We're very skeptical about use of MHT. So we are coming out with 2 updates on these 2 subjects, which will be on the lines of like Fogsi Focus we used to have, and they'll be released in February in the IMS-Con. So osteoporosis, every one of us should have a clear idea how to treat. It is our subject. The women come to us, and we have to, give them better life. We have to take care of our bones, take care of their bones. We have to have clear ideas how not to get into that, this problem of early osteoporosis and menopause. So the topics that you have taken up today, MHT and osteoporosis, Parag, it's very, very important. Even now, the clarity, every time there's something different coming up, how MHT can be used in osteoporosis. Can it be used solely for prevention of osteoporosis or treatment or not? So looking forward to listen to your points, on that. And then the osteoporosis management and endocrinologist perspective. In fact, I'm giving a talk at 8 o'clock on the endocrinology of bone health. So I'm looking forward to catch a few extra points on that I can include in my talk. And then, of course, case-based discussions, which give you, different, ideas about different cases that you can see in your own OPD. So looking forward, Beenal, to the wonderful evening and the very nice topics that you have chosen, and all the best to everyone here, speakers, audiences, everyone. All the best. Thank you.
Yeah. Thank you so much, ma'am, for those words. And we are really looking forward to our own Indian guidelines for following in day-to-day practice. So thank you so much. And thank you, Monica.
Veena ma'am, I also request you to introduce Aarti ma'am as the guest of honor for our webinar today.
Sure, sure. That will be pleasure.
Abhishek,
It's my
can we have the
privilege.
series there?
Yeah.
Yes, ma'am.
Yeah. So it's my pleasure to invite Dr. Aarti Gupta ma'am. She's a very dynamic and vibrant Secretary General of the Indian Menopause Society. And I can say that I am following her footsteps because previously she was the chairperson of the Public Awareness Committee. And she really gives so much insight into how we can actually work और सबको साथ में लेके कैसे चलना है ये आरती मैम मैंने आपसे सीखा है. So I really bow down to you for that. And Madam has received many awards. She is the winner of the Nari Swasthya Pahal Award, Nari Shakti Samman Award, Golden Aim Award, and
Thank you,
Lifetime
Vinal.
Achievement Award. Yeah, so
Thank
Madam
you.
is from Agra, and we are looking forward to come to the North Zone IMS Con Agra, Madam. Over to you. Please give blessings to the webinar.
Thank you, Minal. Thank you so much. Very good evening to all of you present here in this webinar. And at first, I will like to congratulate Binal to be associated with the Fogsi, because I think now it's a very, very big platform and we can go together and do the things together. So the हमारी जो पहुंच है वो बहुत ज्यादा लोगों तक हो जाती है. तो when I am committee chairperson of Club 35 Plus and Public Awareness Program, then that time I tried my best. I can be collaborate with the Foxy, but I couldn't be successful. So, but now you are doing this thing now. It's a very good thing. I am looking for this. So this is very good. The another thing is this: the topic which I've taken today is very, very important, and all of us know that it's a osteoporosis is the silent killer. It's really a disease of the elder people. It started very early. Even it started at the time of the puberty, and even that in utero. So we have to focus on the diet of the mothers, and we have to focus on all the diet of our puberty age childrens. And after that, we have to focus during the pregnancy, and that too we are going to the menopause. They are the patients who are of the premature ovarian insufficiency. Even today, I've got one patient, she is 27 years of old, her FSH is 40. So there's so many of the patients who are coming with the primary or secondary amenorrhea and their FSH is at the range of 40. I mean, they are the patients of premature ovarian insufficiency. These are the patients where we should focus and we should treat them for the osteoporosis. And even the patients who are coming to us for any reason around the age of the 35 or 40 or 45 years of the age, we should screen them for the osteoporosis, and we should go for the DEXA at the age of the 45 years, and we should diagnose the osteopenia earlier so that we can treat the osteopenia and we can save our patients from going to the osteoporosis. Now we are having so many drugs in our armamentarium to treat the osteoporosis. Very recently, I think we will talk about that. Today we are having the endocrinologist and Parag sir, who is going to talk on the MST in osteoporosis. I think it's a very important point. I am not taking much of your time. Thank you, Vinal. Thank you so much for inviting me and for as a guest of honor. Thank you.
Thank you so much, ma'am. And thank you for the insight into the subject.
Thank
Okay,
you.
over to you, Monica.
Thank you, Beenal ma'am. Thank you, Aarti ma'am and Dr. Pushpa ma'am for gracing this occasion. I now declare the inauguration is over, and we move forward to a very important segment of the webinar today, that is the declaration of the results of the Me No Pause essay competition. At the first instant, I would like to thank our judges, Ambuja ma'am, Tripti ma'am, and Manik ma'am for accepting our invitation as a judge at the last minute, and they were very kind enough to go through each and every essay. I must say they have taken a lot of efforts, because there were more than 45 entries for English and almost 14 entries for Hindi essays. I take privilege in introducing each one of them shortly. Can we have the CV slides, please? Abhishek? Yeah. Dr. Ambuja ma'am has been the past president of the Indian Menopause Society. She was the research committee chairperson of the South Asian Committee of the Menopause. She is also retired professor and HOD from Osmania Medical College, Hyderabad, a visiting professor at Savita University, Chennai, and All India Vice President of the Family Planning Association of India. She has been a faculty and a resource person for the National Board of Examination from the year 2001 onwards. We welcome you, ma'am. Our next judge is Dr. Tripti Sharan Madam. She's the Associate Director in, from Black Max Hospital, New Delhi. She contributes regularly to the books, journals, and has several publications to her credit. She is also the SME Elsevier editor to DGES peer review or a DND examiner coordinator. She is a member of the Fogsi Sexual Medicine Committee and the High Risk Committee and Reproductive Endocrinology. She has been an author of many books and the recipient of APJ Abdul Kalam's Appreciation Award of the Wonder Foxian, the most inspiring gynecologist by ET, and the Global Youth Icon Award. We welcome you, ma'am. Our third judge is Dr. Manik Panse, ma'am. She's a senior obstetrician and gynecologist from Jabalpur. She's a director of the Anant Multi-Speciality Hospital there, a past president of the Inner Wheel Rotary South Jabalpur, a member of the Camarac Trust merged with Hospice for terminally ill cancer patients. We welcome you, ma'am. I would first invite Tripti Madam and Ambuja Madam to please share their views on how it was and judging the entries for the competition, and then we go in for declaration of result. Over to you, the judges.
Hi, hello everyone. Good evening, and thank you, Monica, so much. And I must appreciate the organizers for taking such a sensitive topic. And Beenal, hats off to you. It is only because of her that I became a judge today. And trust me, this is the first time I'm judging an essay competition. It has been a learning experience for me because soon I have to be a judge in a Festival of Ideas. So I learned a lot from this. And to be very honest, I thought there will be only 10 to 15 of them. But then every day there were 10 or 15 per day. And we ended up having almost 45 till when we closed it. So before we go further, I just wanted to, a word of advice, if I might, to the organizers that next time when we do it, we should have clear instructions for all the contestants to have one format, like a Word document in a fixed Times New Roman. The size should be 12. So that, we had some people who had just jotted in their notepads and sent us screenshots. Some had sent PDFs and they were not named. I mean, just sharing these things came to my mind because now we will be doing a lot of them. So it becomes easier judging. I'm sure Ambuja Madam would also agree with me there. And as for the contestants, I mean, I'm so blown by their, enthusiasm. And for the last 3-4 days, I've not been thinking about anything but menopause. But just again, a word of advice to them, like, whenever we are writing something, it should be as simple as possible. I was amazed by a typical Tharurian English by one of the contestants. I had to open a dictionary and understand. I could never imagine that. It was wonderful. That way, we had to give him extra marks for English. But we should have a very good, beginning, a very good end, and in between it should flow. So that is the basic idea of essay writing. But all the contestants, they did have the grip of the matter, though some went on MHT, some went on and on about the role of the menopausal woman, how her attitude matters. Of course, that's very true. But I especially gave an extra point to those who talked about the community participation, about the responsibility of the society, about the responsibility and duties of the husband. And the family, because that is very important. The woman is already braving something. We cannot put everything on her head, though she's a primary player. Because we all know that, India as a country has yet to acknowledge the role the menopausal woman is going to play, because at this age, the woman, when she reaches menopause, she's at the peak of her productivity and as a worker as well as an individual. And we are all going to be, some of us are and some of us are going to be at that age. So not only as a doctor, as a person also, we have to be very, very sensitive about this. So I would ask now, ma'am, Ambuja ma'am also to share her thoughts.
Good evening, everybody. Am I audible?
Yes, ma'am.
Good evening, everybody. I really appreciate the organizers especially chairperson of Public Awareness Committee, IMS,
I'm there.
my dear
I
Bina,
can see
for
Bina.
selecting such a wonderful topic. I agree with my friend for all the things
Hello.
what she told. And we did
आप देख
the
पा रहे हैं?
selection of the candidates very meticulously, taking point each one and made the columns, and we gave the marks like that, not selecting on one point, different points, 5
Can you
were
see me
taken and selected. And I'll tell you, the way people have expressed, it is really, really, we cannot say how good it is. And they did a very good job. And each article is very different and creative. That's what is the thing which I really like. And given choice or a given prize to each and every article, but our hands are tied. We have to select somebody or other for the first, second, and third prizes. So we have to select. Otherwise, for all the participants, it's a congratulations for participating. And first, this thing is to Bilal, who selected the topic.
Yes.
It's a wonderful
He's a
experience.
diva.
And thank you all. And thanks to organizers for giving the opportunity. Thank you very much.
Yeah. May I have few words from Dr. Manik, madam? Yes. Manik, ma'am, are you there?
She needs to unmute now.
Yeah.
Madam is there. She told me. I just called her up.
She has
Ma'am,
to
please
unmute.
unmute yourself.
Yeah.
Yes, ma'am,
Manik, ma'am,
unmute
please
yourself.
unmute yourself.
Am I heard now?
Yes, madam. Yes.
Can you see me?
Yes.
Yes,
Okay.
ma'am.
Okay. First of all, I would like to thank Beenal madam for giving me this task. And I received around 12 to 14 essays, and they were really good. And I'm also thankful to Beenal madam's friend, who is my senior, Sandhya Kaushal. I have given first. I judged it on the length and words and the idea chosen by the ladies. They all were writing about MHT and all. I should say, what are the symptoms and signs of menopause. I never wanted that. There was something I would like to share with you all. One lady who really wrote beautiful poem, and that I would like to share with everyone because that is too good. Can I, Beenal?
Yes, ma'am.
Yeah.
Can I share
Please.
it with you?
Yes, madam. Please.
Okay. Let me just find out. Yes. इस गुलिस्ता की लाज है तू, धरती माँ का चिराग है तू, उम्मीदों से भरा ताज है तू, कड़ी धूप का एहसास है तू, मंजिलों की रफ्तार है तू, हर काफिले में लाजवाब है तू, हर मुश्किल पड़ाव की मिसाल है तू, इस नायाब जहां की मलिकाएं सरताज है तू, रजो निवृत्ति को संभालने की शाही कमान है तू, हर आयु में आशा की किरण है तू, मेरी माँ, सास, बहन, चाची, दादी, नानी, सहेली की है तू, एक परिपूर्ण स्त्री है तू, रजो निवृत्ति से बेखबर क्यों है तू, बटोर रजो निवृत्ति का आज सही ज्ञान है तू. I really liked it, and she ended it with रजो वृत्ति का जो काल है, यह ना तो कोई भूचाल है, एक आयु का महाजाल है, बढ़ती उम्र का आगाज है, यौवन पर झुर्रियों का ताज है, बालों की सफेदी का सुनहरा जाल है, नई ऊर्जा से संभालने इसे आज है, खुशियां बटोरने का नया साज है, निवृत्ति में छुपा एक राज है, इसे सकारात्मकता से संजोना लाजवाब है, रजो निवृत्ति आजादी का अनोखा अंदाज है, यह तो अटल है, एक वरदान है, हाँ एक वरदान है. I gave her first prize because she really knew what she is writing, and I want to tell people that we don't want hormone replacement therapy. We never wanted this. We just wanted something new. Then one girl, she wrote that there is nothing special in the lives of men. और महिलाओं में तो बहुत सारी चीजें हैं, मेनार्के है, डिलीवरी है, मेनोपॉज है, so the life is full of excitement. So these are the few things which I have taken into consideration. Hello.
Yeah, yes, madam. Thank you
Yes.
so much, madam, and
Okay.
thank you for bringing out the various perspectives. And आपकी बात सही है, madam. जब हमने ये me no pause topic दिया, that time our idea was to bring out the perspective, various perspective in the people's life, and mainly to end it at an optimistic note. मतलब
Yes.
जो futuristic and optimistic vision, and उसको एक नए तरीके से देखना है, नए जरिए से देखना है.
बिल्कुल,
So thank
बिल्कुल.
you so much, madam, and thank you for helping us with judging the contest. Now, Monica ji, can we declare the results now, please? Can we have the slides?
Yeah. Abhishek, can we have the slideshow? I request Tripti ma'am and Ambuja
Yes.
ma'am to declare the English results.
Okay, so at the outset, I would say all of them were winners. 46 was not, 45 was not easy to judge, and the points were just 0.1, less. So the third prize winners are Dr. Akanksha, Dr. Geeta Gupta, and Dr. Prachi Dhawan. They got almost identical 1 marks. So can I ask Ambuja ma'am to announce the second prize?
Yeah, I feel very proud to announce the names of the participants and awardees. The second prize goes to Dr. Reena Prabha, Dr. Sumati Anand, Dr. Sheila Sharma, and Dr. Vidya. At this point of time, I just want to tell one word, saying that whoever is handwriting with a hand and then taking a photocopy is, I think somehow, Bina, from next time onwards, we should announce that it should be a typed one.
Yeah.
With letters.
Sure, madam. Yes, madam. I understand.
Yeah, because it took some time, because we cannot deny them or we cannot discard them. No, so we have taken into consideration and then did. And congratulations to all the 4.
Next slide, please.
Ma'am,
The first prize.
Yeah, the first prize, it goes to Surabhi Saini, Dr. Deepika Divani, and Dr. Purvi Patel. I told you in the beginning itself, it was so difficult to discriminate and say who is first, who is second. So we are forced to give the prizes in such a way who equally got the same marks. And so congratulations to all of them.
So, well, this is a kind of consolation to us that, we have not left, some more of them, because we really did not want to. And as ma'am was saying, it was very difficult, and we very, very meticulously, even gave marks to everyone, the thought, the matter, everything, even those pictures and poetry and everything. So the consolation prizes, they went to Dr. Neha Katare, Dr. Amrita S. Dharman, Dr. Kamla, Dr. Meetu Babel, and Dr. Anit Kumar. And Dr. Anit is one person I would really want to know where he got his English training from.
Yeah, that's what Tripti
That was
wanted
amazing.
to tell about the Anit.
Yeah,
it was really
amazing.
good.
That's a very Oriental Shakespearean English.
Manik ma'am, can you please declare the Hindi results?
Yeah, the third prize goes to Nikita Bagri and Dr. Sonal Gupta. They were almost same. The marks were same.
Yeah, next slide, please.
Next is Dr. Dipti Gupta and Dr. Sweetie Soni.
The next slide.
Yeah, this beautiful poem was written by Dr. Shweta Manvatkar. She is from Chandrapur. Beautiful thing. Beautiful essay she wrote. Thank you.
Thank you so much. Thank you, ma'am. Thank you, all the judges. And I would like to
Okay,
congratulate all
okay.
the participants for participating and sharing and venting out your views. And you are really multi-talented doctors and doctors at the same time literary genius. So everybody who has participated is a winner. Thank you so much, and we move on.
Hello, if you permit me, I have few lines jotted for menopause. Can I say?
Yes, ma'am.
Hello. कौन कहता
Yes,
है
ma'am.
बस यह तो शुरुआत है तस लगता है पंख फैलाऊं अपने लिए जीऊं जीवन की सारी खुशियां समेटूं जो भी था कुछ अधूरा सा अपना झट पूरा कर लूं वो सपना कि न कहूं कि पहले जिया नहीं कुछ किया नहीं पर अपने लिए नहीं अपनों के लिए था जो न समेटा अब पल में छूट जाएगा सब समय है कम काम है ज्यादा रह जाएंगी अतृप्त सी अधूरी सी कुछ आशाएं थैंक यू
Okay, wonderful, ma'am. That was amazing. Thank you.
Thank you. Thank you, Beena. Okay.
Bye, ma'am. So, Monica ji, we can continue with the scientific session now.
Yes, ma'am. Thank you, Ambuja ma'am. Thank you, Tripti madam. And thank you, Manik ma'am, for accepting our invitation and being the judge. Heartiest congratulations to all the participants and the winners. We would also like to thank Corona Remedies because they will be sending mementos to all the winners of the competition. I now move forward with the academic session. Our chairpersons for this session are Dr. Sudha Sharma ma'am, Dr. Preeti Sharma, and Dr. Kalyan Baramde sir. Can we have their series, please? Dr. Sudha Sharma ma'am is a former professor from the Department of GMC Jammu. She has been the Vice President of IMS. She is the Vice President of IMS the current year and the Secretary General for the year 21-22. She has been the Honorary Professor of IMA, the Managing Committee member of TCS Society of India, and the Editor-in-Chief of the Journal of Midlife Health from the IMS from the year 16 to 18. She is also the member of Editorial Board of the South Asian Federation of OBGYN Society Journals. And
Thank you, Monica.
General of the JK Science Journal of Education. Thank you, ma'am. We welcome you to the session. Our next chairperson is Dr. Preeti Sharma, madam. She is the master trainer of Fogsi RAC, Lakshman Manyata trainers. She has been the president of JOGS from the year 2022, a recipient of DIRA Award and the Fogsi International Achievers Award for the year 23.
Thank you, madam. Thank you.
Thank you, ma'am. We welcome both of you to share the session. Our next chairperson is Dr. Kalyan Baramde sir. He has been the chairperson of the Public Awareness Committee Fogsi in the last tenure. He is also the Joint Secretary of IAG and the convener of Mission Save the Uterus Fogsi, an executive member of the Maharashtra State ISAR, a chairperson of the Infertility Committee Amongst for the current year, and president of IMA Latur for the current year. We welcome all three of you to please conduct the scientific session.
Yeah, so at the outset, I would like to thank the Public Awareness Committee of Fogsi as well as the Indian Menopause Society for giving me an opportunity to chair this session. And it's my pleasure to introduce Dr. Parag Binewale, who actually requires no introduction to all of us. We know him very well. He is a senior consultant in Pune. He's a PG teacher and unit head at the Kamla Nehru Hospital. He has been president of Pune Obstetric Gynae Society in 22-23. He is the vice president of ICOG currently. He's the president. He was president of Menopause Society from 2018 to 22, and has been the secretary of ICOG and has held many administrative posts.
Yeah.
He is the
Thank you, Dr. Preeti. Thank you.
Yeah.
Don't waste time in the reading.
Yeah,
Thank
he
you.
has contributed many books and journals, and he is also recipient of the CS Down Prize. Welcome, Dr. Parag. We are waiting for your deliberation.
Yeah. Thank you, Dr. Preeti, for those kind words. Can we have others muted, please? I think Reshmi,
Yes,
there's
sir.
a
Yes,
voice
sir,
coming from Reshmi.
Yes.
I bring greetings from ICOG and my parent society, the Menopause Society of Pune. It's indeed a pleasure to be part of this program. Thank you, Binal. Thank you, Monica. Thank you, Priyankur, for the opportunity. It's indeed a pleasure to be talking in front of a few of my very favorite people, my favorite Pushpadi and Dr. Ambuja. I must acknowledge Madam Ambuja's, because last week I was in Hyderabad delivering a named oration after her. So, Madam, I'm really grateful to you for considering me worthy of being an orator of your name. So, thank you for that honor. I will be speaking on something which many a times we as gynecologists do not come across, but I think we should be aware about this particular condition. And I'll be talking about menopause, hormone therapy, and osteoporosis. India, all of us will agree, is in demographic transition and the life expectancy has increased. So what has happened is we have become an aging nation, because from 81 million senior citizens, now there would be about 325 million in the year 2050. Osteoporosis is not only a problem in our country, but it is a global problem in general. There are fractures caused worldwide every year from osteoporosis in over 8.9 million people, and women over the age of 50 are more prone for it. So every 1 in 3 women faces the wrath of osteoporosis and the complications related to it. And our country is not behind. This is an old slide which talks about the prevalence of osteoporosis in India, but the current statistic, the current study, which was published a few months ago in our JMH, says that overall prevalence of osteoporotic fractures amongst postmenopausal women was 82%. 37% of them had osteoporosis, while 45% of them had osteopenia. And these are the situations which may be prevented if we tackle them at the right time during the window of opportunity of perimenopause, when many of these women come to us seeking help for other conditions. So all of us know that osteoporosis is a clinical diagnosis, and it is essentially made in presence of a fragility fracture, particularly at the spine, hip, wrist, humerus, rib, pelvis, without measurement of bone mineral density, wherein the low bone mass or osteopenia is defined as a T-score between -1 to -2.5. So when we think of osteoporosis, we have to understand that there are so many factors which are responsible for osteoporosis, the first and foremost being female gender. So our women, especially of advancing age, who are small built, are more prone for this silent killer that is osteoporosis. So the calcium and vitamin D deficiency, sedentary lifestyle, and smoking alcohol and caffeine would add woe to the worsening of the situation in our women. There are some additional factors which specifically are pertinent in our country. First of all, the dressing pattern. The salwar kameez, burqa, etc. are the ones where most of the body parts are covered, and our women are not exposed to the sunlight, and then they are deprived of a good natural source of vitamin D. Our skins are much darker than the Westerners. That also is a hindrance. Our work culture is now becoming more and more indoors, so there's hardly any sun exposure, and a genetic factor could be one of the reasons why we get weaker bones at a later date. So why bone health in our country suffers? And it is because of the social practices, poor awareness about the condition, and of course, calcium and vitamin D, or should I say lack of calcium and vitamin D in diet and supplements. In general, we as Indians are habitually low intakers of calcium. So right from adolescence, in pregnancy, lactation, perimenopause, we tend to take less of calcium, which really becomes troublesome as we start aging. Milk and milk products are good sources, but they are really expensive commodities. Our diet is primarily vegetarian, so we tend to consume less of calcium. We have phytates and oxalates in diet, which become a hindrance in absorption of the calcium. And unfortunately, there's no national program for bone health. There are, of course, issues related to vitamin D, and our diet also is devoid of oily fish and other vitamin D containing food. And the pollution does play a major role, and we in general tend to avoid sunlight in spite of having abundant sunlight in our country. So vitamin D deficiency in general is a major contributor, not only in the rural areas, but also in the urban population, and it's making our women prone for osteoporosis. Let's not talk about social issues. All of us are well aware about the gender discrimination, where the men or boys are given preference over girls and women. And then there are certain issues in the bone health management, because we are really not aware about these issues. There are no fracture strategies. There is lack of coordinator-based care of women with fractures. Osteoporosis, unfortunately, is not a health priority, and there is a lack of audit and quality indicators. So there's a huge burden of fractures in our country, where our population is spending thousands and lakhs of rupees in management of fractures, which could be avoidable to a certain extent. So in our country, the hip fracture is said to be 163 per 100,000 as compared to 121 in men. And let's not forget that 1 year mortality after hip fracture is 30%. Of course, there are other fragility fractures and vertebral fractures which are so common in our women and really trouble our women in the menopausal age group. So there are certain clinical risk factors for fractures, which include the glucocorticoid therapy, secondary osteoporosis, which could be because of premature ovarian insufficiency, malabsorption, inflammatory bowel disease, etc. So it is really important that we screen our women. So how do we do it and whom we screen? The Indian Menopause Society has very categorically put across the risk factors. There are certain modifiable risk factors: low BMI, smoking, alcohol. We can certainly modify it. What we cannot modify are the non-modifiable factors, which include the gender, advancing age, prior fragility fracture or family history of fractures, but we can still try and improve on the environmental factors, which include nutrition, sunlight exposure, and relevance of risk of falling, which increases with aging. Of course, WHO has described OSTA as a risk assessment tool. And then when we calculate the scores, the scoring is, if it is less than -1, we call it low. -1 to -4 is moderate, and less than -4 is supposed to be high. All of us are also aware about FRAX, and let me tell you that these are tools, really simple tools. FRAX, in fact, is an online tool which can give us a fair idea about the 10-year probability of fracture with bone mineral density. So there are some women where we would certainly like directly to have a DEXA scan, which includes all postmenopausal women who are more than 5 years into menopause, postmenopausal women with less than 5 years into menopause with risk factors, women in menopause transition with secondary risk causes, and this would include a big chunk of premature ovarian insufficiency, where we are getting a lot of women these days, and radiological evidence of osteopenia and presence of vertebral compression fractures. Coming to management, and when we talk about management of osteoporosis, we always start with nutrition. So a good nutritious diet, which is rich in calcium. All of us are aware about these sources of calcium, but wherever are women who can afford good food products, they should consume primarily good food products in order to obtain adequate amount of calcium. Of course, those who cannot afford, they can certainly pop a pill, but to make sure that 800 international units of vitamin D and 1200 milligrams of elemental calcium is consumed on a daily basis. And let's not forget the lifestyle measures, because these are really two important pillars to prevent osteoporosis. So adequate nutrition, regular weight-bearing physical activity, at least 30 minutes on most days of the week, that is 5 days a week at least. Smoking cessation, no or moderate alcohol intake. Prevention of fall is extremely important. And then we should try and avoid drugs which would increase bone loss, such as glucocorticoids. Coming to calcium, so whenever we are prescribing calcium, we should make sure that we give small frequent doses. Calcium carbonate is the only salt which has to be given with food. Rest others can be given irrespective of food, and there is no consistent difference in efficacy shown, so the woman can pop up a pill during daytime or even at the night time. So a maximum single dose should not be more than 500 milligrams of elemental calcium. So total 800 to 1000 to 1200 milligrams per day. Safe upper limit is said to be 2500 milligrams per day. How can we reduce calcium requirement? And that is possible by consuming low salt and protein intake. So when we talk about calcium, what is the role of other supplements like magnesium, isoflavones, vitamin K? Theoretically, they do show some benefits, but not many studies are proving it. In addition of trace element and minerals in suboptimum quantities is widely practiced, but it is not of any use. And there is no role of active vitamin D, that is calcitriol, in management of osteoporosis in general. And that brings us to the hormone therapy, which is so important in management and especially prevention of osteoporosis. So let's first talk about effect of estrogen on bone. And the most important aspect is the prevention of osteoporosis. The WHI trial and the PEPI trial have established that there is a postmenopausal decrease in bone density, and it is attenuated by estrogen, resulting in a lower risk of fracture. So my appeal to everybody, women who are higher risk of having osteoporosis, please do not hesitate to offer them hormones if they desire to have, and if they are eligible to have hormones for management of menopause. So when we also look at the WHI very critically, and as compared to placebo, the estrogen and progestin therapy certainly reduced possibilities of hip fractures. So there were 5 fewer hip fractures per 10,000 persons per year in women who received hormone therapy during the WHI trial. So there are methods to slow bone loss, and when we think of exercise as one of the best methods, the study compares exercise vis-a-vis exercise and calcium vis-a-vis exercise and estrogen. And what was found out was exercise along with estrogen is probably the best to improve the bone health. The bone loss was significantly slowed or prevented with either exercise plus estrogen, and even with exercise plus calcium supplementation, though estrogen was little superior to the only calcium supplement. What is the effect of estrogen dose on change in BMD in postmenopausal women? Now, this study did talk about placebo versus 3 different doses of estrogens. Mind well, these are all conjugated estrogens given in the dose of 0.3, 0.625, and 1.25 milligrams. Now, all of us know that our Indian Menopause Society has very categorically said that we should be starting with the smallest possible dose. But when we think of prevention, we have to take everything into consideration and offer a good package to our women in order to prevent osteoporosis. So what the researchers have said that the dose of estrogen, 1.25 milligram, was probably the best. Not many of us use such high doses, but at least we can think of giving the standard dose of 0.625 milligram to women who are more prone for developing postmenopausal osteoporosis. So when we think of giving hormone therapy, what is the take on women who are taking it continuously? The studies have shown that women who are taking estrogen therapy continuously are definitely better off as far as the bone mineral density is concerned. So this can be continued safely with close and vigilant monitoring and supervision of these women. Estrogens, when compared with bisphosphonates, were found to be superior, and they had a better impact on the bone mineral density. So estrogen in combination with norethisterone, estrogen were compared to estrogen and medroxyprogesterone. And of course, the alendronate was also considered in the studies. And what was found out was estrogen and norethisterone combination probably worked better than alendronate in management of postmenopausal osteoporosis. What is the role of only progesterone? We all know progesterone inhibits bone resorption and has some beneficial effect on bone density, especially when given to estrogen deficient women. So the beneficial effect of progesterone on bone mineral density is much smaller as compared to that of estrogen. So the role of MHT is all preparations, including low-dose, non-oral routes of estrogen, are effective in preserving bone mass. So don't hesitate in prescribing hormone therapy to women who are at risk for developing osteoporosis. Estrogen progesterone therapy or even estrogen therapy may be used for the prevention as well as treatment of osteoporosis in the early postmenopause in symptomatic women, unless there is a specific contraindication to it. ET or EPT, which prevents all osteoporotic fractures even in low-risk population. So it does increase the lumbar spine BMD up to 7.6%. It improves femoral neck bone mineral density, and it does reduce the risk of spine, hip, and other osteoporotic fractures by almost 33 to 40%. And this is a grade A evidence. So we should really cash on it and help our women who are suffering. So MHT should not be started solely for bone protection after 10 years into menopause. So IMS has very categorically stated that women who are over 60 or women who are more than 10 years into menopause, MHT is a strict no-no, and this also holds true in this situation. And in women who have extremely important in these women till the natural age of menopause, because these are the ones who are more prone for development of osteoporosis, and just a simple solution like hormone therapy would help them. Let's not forget tibolone. Tibolone may be preferred to MHT in symptomatic menopausal women with mammographically dense breasts, because we would be a little concerned using MHT in these women. It can also be used as an ADVAC therapy with GnRH analogs for relief of vasomotor symptoms and to maintain BMD. And tibolone should be used with caution in women over 60 years and should not be used in those who have a strong risk factor for stroke or even breast cancer survivors. SERMs are also very effective, and they are found to be beneficial in reducing new vertebral risk factors. Many of us have used raloxifene in the past, and it does have a good impact in postmenopausal women in osteoporosis and even in women who have osteopenia. And it also gives a simultaneous reduction by 76% in the risk of invasive breast cancer. This can be used as a therapy for prevention and treatment of osteoporosis, especially in women who are at a higher risk for breast cancer. And raloxifene and estrogen are associated with similar increased risk of venous thromboembolism. However, no cases of VT were reported amongst young remember and offer to our women. What is new in it? Bazidoxifene is the new SERM, not yet available in our country, but a combination of conjugated estrogen and bazidoxifene is proved to be effective in relieving menopausal symptoms as well as for prevention of osteoporosis. And of course, these are the guidelines which talk about the pharmacological intervention in postmenopausal women beyond the age of 50 years. And the International Osteoporosis Federation has presented this audit for the Asian population in 2009. And then they recommend as preventive strategies, which include creating awareness, promoting healthy lifestyle, calcium, vitamin D supplements, food fortification, and not to forget MHT. They also suggest that there should be a registry. Unfortunately, we don't have one, and there has to be a good fracture liaison service. And of course, there are so many avenues for research in our Indian population. So to summarize, osteoporosis in our country is greatly underdiagnosed and undertreated. Problem is it's particularly acute in rural area, which has poor healthcare facilities. Women are definitely more vulnerable to men, and bone health needs to be prioritized as public health problem. Therapy would include calcium, vitamin D, lifestyle, and medication that greatly includes menopausal hormone therapy whenever appropriate. So thank you very much. And once again, thank you, Public Awareness Committee of Fogsi and Public Awareness Committee of Indian Menopause Society, for giving me this opportunity to address this very, very pertinent issue of osteoporosis. Thank you very much.
Thank you so much, Dr. Parag, and congratulations for an excellent presentation. You know, it's a feast to listen to you always. You have covered the whole subject in a very simple and crisp manner. So I want to share few things which from my side, which I have learned, from the literature and over the years. We all know that it's a chronic non-communicable disease, cannot be cured. So whenever we make a choice of treatment, it should always be made in the context of more comprehensive long-term strategy. And we should not treat the BMD alone, because risk assessment, when is included along with BMD, then the treatment is more beneficial. So please don't treat BMD alone as well. Now, the endorsement has been made by various societies: International Menopause Society, North American Endocrine, European Andropause Society, that looking at the benefit risk ratio, MHT should be started as first option with low to moderate risk people, not in all cases where specific bone active medications are not warranted. That means if you cannot give other medications, only then your choice should be MHT. Of course, if she has, indications for MHT, vasomotor symptoms and all those things, if it is not contraindicated, then it should be the first choice. Number two is effect of estrogen on bone is more dose dependent than it is, route of administration. Sometimes they say that if you give, transdermal MHT, it is more, effective, but it would be more on dose. What is the dose of estrogen you are giving? That would give more benefit to the patient. And one thing which was very interesting to know, that we know that there is a 20% loss of collagen in first 5 years of menopause, and our intervertebral disc, that is 100% collagen, which makes nearly 1/4 of the length of the spine. Estrogens have an action on this intervertebral disc, and thus they maintain the disc space, the length of the spine, which no other, treatment for osteoporosis does. So MHT here, estrogen here, has the benefit which acts on the intervertebral disc, and also it gives us a muscle strength as well. Tibolone, I think you've taken care so nicely. And then I also want to share one thing, that why we are taking severe osteoporosis as -2.5 and not any other number. It was so interesting to know that this cutoff was, based on, made by WHO. It was based on close association between the prevalence of fractures at this cutoff point. So maximum fractures were occurring at this point, and lifetime risk for fracture was more at this point. So that's how -2.5 has taken as severe osteoporosis. And also I learned that men at all stages of their life have more BMD than we as females. Their skull is harder than us, but gray matter, I don't know. This is up to you to decide. And whenever you have to celebrate, don't go beyond 2 drinks, because less dose, 2 drinks, they are beneficial. They are stimulant to bone. But if you go beyond 3, that is detrimental to bone health. Thank you. Thank you so much. And thank you, Beenal, for giving me this opportunity to chair this session.
It was great pleasure, ma'am, and you really did justice. And we are looking forward to the guidelines for osteoporosis, and you are contributing in a great way. Thank you so much, Sudha, ma'am.
Beenal, our IMS guidelines are there on osteoporosis.
Yes. And ma'am
they are
is
excellent.
working on.
They are excellent.
I think Beenal is talking about the updates we are going to publish.
I'm talking about the update. Yes.
Yeah.
Ma'am, we request you to now please carry forward with the second session. Sudha ma'am, can you introduce our speaker?
Yes,
Dr. Kalyan,
it would be my pleasure to introduce Dr. Rupal Panchani. Can I have her CV, please? Dr. Rupal is MD DNB endocrinology. She is a consultant endocrinologist at Anjana Endocrine Clinic and Edicure Super Specialty Hospital. She has received prestigious NBE Gold Medal in Endocrinology 2014. She's IMA Gold Medal in MBBS 2007. She's Best Resident Doctor of Shri Ganga Ram Hospital 2013. She is Torrent Young Scholar Award 2013, has several publications in national and international journals and several poster and paper presentations. So over to you, Dr. Rupal, a very young, dynamic endocrinologist. We are eagerly waiting to hear from you.
Thank you, ma'am. So I'll be discussing about things regarding the osteoporosis therapy. I hope my slides are visible.
Yes, ma'am, visible. Just make it full screen, ma'am.
Yeah, I've done it.
No, it's not full screen.
Yes,
yes,
no. Perfect.
Okay, so I'll be discussing about osteoporosis management apart from the HRT, which was just discussed in this talk. So from the endocrine perspective, what are the things which we can keep in mind? I won't be taking this risk-based screening because sir has already discussed about what are the risk factors and who are the high-risk women who are likely to have osteoporosis and who should be screened with the assessment. Quickly coming to the available osteoporotic therapies that we have so far. We all know about the availability of bisphosphonate. They have been with us for almost last 15 years or more than that. And most commonly known bisphosphonates are the oral bisphosphonate, respectively the alendronate. Orthopedicians most commonly use the ibandronate. And IV bisphosphonate is zoledronic acid, which we most of the time use. As endocrinologists, we most of the time use IV bisphosphonates, namely the zoledronic acid. Then the same thing has come in last 5 years is denosumab. In last 1 or 2 years, it has been used more as a treatment for osteoporosis. So you'll come across many of your patients using denosumab or prescribed with denosumab. And you would also have known, or you would have also used teriparatide, that is parathyroid hormone analog. What we have new is a PTH-RP analog, that is PTH-related protein analog, that is abaloparatide. It's not yet available in India, but very soon it will be available. It is, as of now, it is one of the most efficacious agents in terms of spinal fracture prevention. And we have something like denosumab, we have romosumumab, which is anti-sclerotin mab. Now this denosumab and romosumumab, these are monoclonal antibodies. They work at the level of osteoclast. So denosumab is a rank ligand inhibitor. Rank ligand is something which is elemental in osteoclastogenesis, that is bone resorption. Now, what are the adjuvant therapies? Adjuvant therapy are mainly calcium and vitamin D, endurance and weight training exercises, nutrition, fall prevention, and correction of metabolic, hormonal, and neurological illness. We all know that osteoporosis occurs at an age where patient is equally susceptible to having diabetes, thyroid disorders, neurological illnesses, at the same time, other hormonal illnesses as well, like parathyroid abnormality, adrenal cortisol abnormality. So these are also which are likely to be found at that age. So calcium and vitamin D, we all know, but there is a misconception among the general public that if you are taking calcium and vitamin D, that is enough for treating osteoporosis. So it is not always true. They are named as adjuvant therapies in most osteoporosis guidelines, namely the Endocrine Society guidelines, AACE guidelines, and the NOF guidelines, where they have said these are mainly the adjuvant therapies. So sometimes our patient keep popping calcium and vitamin D, thinking that this would be enough to manage osteoporosis, but it is not so. And at the same time, we many times we just prescribe calcium and vitamin D, but the endurance and weight training exercises have to be explained to the patient. In our country, most of the time exercise means walk. So when you tell your patients that are you exercising, they will say, yes, we go for walk regularly. We need to emphasize to them that walking alone will not be the adequate endurance and weight training exercise. Similarly, paying attention to nutrition. Now, this topic of nutrition is so much confused these days because on one hand, you have people advocating gluten-free diets, intermittent fasting, and then you have people doing keto diets and other vegan diet and all. There's no offense with any of these diets, but then sometimes incomplete knowledge about these diets and self-prescription of these diets also compromises nutrition to a huge extent, namely the calcium intake and the protein intake. And that is why also we see more osteoporosis even in youngsters these days. Even before their age of having osteoporosis, we see women with low bone mineral density. Fall prevention, sir, has already discussed. Going a little more in detail of endurance exercises. So what is actually endurance and weight bearing exercise? Now we see so many women coming to us with Achilles fracture, wrist fracture. Now wrist fracture is one of the non-vertebral osteoporotic fracture, but it is attached with a lot of morbidity because women cannot work on their own. They are dependent. They need some help in most of the activities if they have this kind of fracture. And many times it's very difficult to heal these kind of fractures, and they require plating and nailing and so many other things. So these were our age-old weight-bearing exercises that women used to have back in these days. I'm not saying that they never had osteoporosis. They had osteoporosis, but the reasons were different. But they had their own share of weight-bearing exercises. You can see these are the regular forearm weight-bearing exercises. These all are forearm weight-bearing. If you see anybody's DEXA scan, you will see the forearm is the weakest. If the DEXA score at hip is -2 and spine is -1.8, then the forearm would be -3 or even more than that. That is because in our day-to-day life, forearm weight-bearing exercises are reducing. These were the old things where there used to be a forearm weight-bearing. Now, if we can't do any of these things, then we can probably do this. And these are some of the places where we can have forearm weight-bearing exercises. Even in males, even in male doctors, I have seen forearm is the weakest bone in their body. So they are more prone to develop osteoporotic fracture at the level of wrist. So now this is one concept that I have devised on my own to make things very easily understandable to our patients and the other fraternity, that what is actually osteoporosis. So this is the wall, foundation, brick, and the cement theory. What is the foundation? So the foundation of our bone mineral density is our early years of life, right from the intrauterine period, what our mothers ate, how much food in nutrition they ate, and then was our birth weight at 1 year of life. These are all the factors that influence your bone mineral density. Childhood and pubertal nutrition, protein intake, calcium and vitamin D. It's very sad that after the age of 35, 40, 45, women start thinking about their calcium intake and vitamin D pills they start looking for in the market. But it's actually the adolescent women and the girls who should be subjected to regular calcium and vitamin D intake as well as analysis. Weight-bearing exercise in the early years, which you have done, pays you off in the later years after menopause. And also the genetics. We have families who are more prone to osteoporosis. So this is our foundation. We are already had our foundation. Now at this stage, I think most of us in the audience, we all have our foundation. Now we have to do with that whatever foundation we have. But we can change foundation of the young girls, young female patients coming to us, our daughters-in-law, and our granddaughters. We can still do this. So remember, this foundation is the most important part, and it is in very early years of life. So this is the foundation. So any wall, if it has a very good foundation, it is likely to last longer. Then the wall. So the bone is like a wall. Now the wall has both. It has a bricks as well as cement. Similarly, our bone has a microarchitecture and whatever calcium, vitamin D, magnesium, and sodium that we take works as a mineral deposition. So it is like this wall. You can see the cement. Cement is our calcium, magnesium, and vitamin D, and the architecture is the brick. So osteoporosis means we have lost the integrity of these bricks. So this is somewhere our bone, how it would look at the age of 40 to 50. This is how it would look between 50 to 60. And this is how it would look after the age of 60. So this is how your bone exactly looks, because everybody cannot interpret DEXA scan. So this is almost a pictorial description of the DEXA scan that you will have at your 40s, 50s, and 60s. So how do we make this wall more sturdy and more long lasting? So weight bearing, as we discussed, hormones, sir had already discussed, and calcium, vitamin D, magnesium, and sodium. These are the salts between it two. Now we keep talking about calcium and vitamin D, but nobody talks about sodium. This is also equally important. People who are likely to have a higher salt diet in the early years of their life and the later years are likely to have more osteoporosis. People who are likely to have excess of non-vegetarian diet, although it is said rich in protein, but it also produces acidemia, which leads to more of calcium washout from the bones. So how do we make this wall very sturdy? So it is only the integration that we have to change. So how do we understand these osteoporotic agents? Now, early in this talk, I had told about the bisphosphonates, denosumab, and teriparatide. So our bisphosphonates and denosumab are anti-resorptive agents. That is, these agents prevent the washout of bone. And bisphosphonates and denosumab are mainly the drugs that we use. So this, if our wall is damaged, we have, this is one option. What we do is we apply the plaster. Similarly, bisphosphonates do the same thing to our bone. They apply a layer over the affected bone so that no more bone is washed out in the coming years. So this is how bisphosphonates work. This is also plastering a wall, just like you give anti-resorptive agents to your bone. This is slightly a sophisticated kind of plaster in the above, and the lower one is a regular kind of plaster. The above one indicates denosumab. Denosumab is slightly a better agent when we talk about anti-resorptive agents. It improves our bone integrity in a much better way compared to the existing bisphosphonate, especially when we are talking about the fracture risk prevention at hip and the non-vertebral fractures. So this is almost like, this is how it would happen if your bone receives bisphosphonate. It will improve, it will strengthen your bone and reduce the risk of fracture. Now coming to the anabolic agents. Anabolic agents, they help in producing and depositing new bone. So they improve the bone architecture. All the holes that are formed in the bone because of osteoporosis, they can be filled and it will almost try to resemble the new bone. So they are the new bone forming agents. So if this is your bone, before starting the anabolic therapy, this is how your bone will be there. Now, the basic difference between anti-resorptive therapy and the anabolic therapy is the anabolic therapy starts from a scratch. So it will first remove all the affected bone and then it will start producing completely a new bone. So it's like you removed the whole broken wall and then you made a new wall. Why I am giving this example? Because I want you all to understand that many a times patients take teriparatide only for 3 to 6 months. 3 to 6 month teriparatide is not going to help them in any way because these anabolic agents at least require 1 year to form a good quality new bone. That is why this picture I have given, it might look silly, but this is why I want to explain that teriparatide, when you give to a patient, first 6 months, it will not form any new bone. First 6 months, it will just try to start from a scratch and gradually at the end of 1 year, you will see new bone formation. I can say this because the bone markers which are done to understand how much new bone is being formed and how much old bone is being preserved can tell you that what is the intensity of the new bone formation in the body when you are taking the teriparatide. Now, teriparatide, that is the anabolic agent, will help you to produce new bone at the level of spine, at the level of hip and the non-vertebral areas. After you have formed a new bone, it is again necessary to consolidate it with again anti-resorptive therapy. Otherwise, whatever new bone we have formed, it will be again washed out because menopause is going to prevail. It's not going to go anywhere. So if you have taken teriparatide for 2 years, it is very important that whatever new bone you formed at the level of spine or hip, you have to preserve it. And to preserve it, we have to use anti-resorptive agents. That is our bisphosphonates or denosumab. So this is an example that you formed a new wall and then you are going to reinforce again so that it doesn't get washed out, it doesn't get broken. So this is how your bone will look after you have taken 2 years of teriparatide and then you are taking regular bisphosphonate therapy. What is the role of muscle strengthening and exercise? I told in the very beginning that these are very important. Endurance exercises are as important as taking your calcium and vitamin D regularly, because it is a very common thing. If you have something which is made up of glass or something that is fragile, you pack it in a very strong box. Similarly, if your spine and your hip is fragile, you need to pack it in a strong box of muscle. So you can see that all our bones are surrounded by muscles and ligaments and tendons. So if our bone is fragile or brittle, why not to strengthen the muscles that support our bones? So that is why muscle strengthening and endurance exercises and weight training are required. So once you have made your wall, you can choose to reinforce your wall by these iron bars. So these exercises, they actually act like these iron bars. They will not allow your bone, or they will not allow your calcium, and they will not allow the microarchitecture of bone to be affected if you are doing regular, as Dr. has told in his previous talk, that if you are doing regular muscle strengthening exercises, this will exactly, your bone will exactly look like this after 1 year of regular exercises. So coming to the in short about bisphosphonates. Bisphosphonates, I told that initial treatment of bisphosphonate is recommended to reduce the fractures. So the first agent you can choose is the bisphosphonate. Now bisphosphonate, as we discussed, they are of various types. Most simple and easiest to use is the zoledronic acid. After you have used bisphosphonate for 3 to 5 years, you need to give a holiday, because the bone will need some remodeling for 2 to 3 years after 5 years of bisphosphonate, which is also called as a bisphosphonate holiday. So there you can temporarily discontinue bisphosphonate and keep checking for the bone mineral density by doing DEXA scan or doing the bone marker test. And these are the fracture risk reduction. Now, this is very important to tell our patients that whenever we are giving any kind of osteoporotic therapy, whether it is HRT or whether it is bisphosphonate or denosumab, it is not going to make the fracture risk zero. This most of the time people feel that if they have spent 10,000, 15,000 rupees a year for osteoporosis therapy, they should not have any fractures. It is not like that. These agents will reduce the fracture risk, but that will not eliminate completely the fracture risk. So the fracture risk reduction with zoledronic acid, if you give at the level of spine, is 50 to 60%. Means if you are on a regular zoledronic acid since last 2 to 3 years, your probability of fracturing your spine will reduce by 50 to 60%, but it can never be zero. Similarly, if you are taking regular zoledronic acid or bisphosphonate, your probability of fracturing your hip will reduce by 30 to 40%, but it will not be again zero. Non-vertebral, mainly the Colles fracture, the wrist fracture, the humerus fracture, they will fracture risk reduction will be around 20%. It is almost the same if you look at all other bisphosphonates. Here it is very important to note that ibandronate is only for spine fractures, spine fracture risk prevention. It is not working at hip and non-vertebral fracture, but it is sad thing to see that most of our patients are on ibandronate. Patients that we receive from orthopedicians or physicians, they are actually on ibandronate. So ibandronate is not helping you to reduce hip fracture. And if you look at the morbidity and mortality of hip fracture is much high compared to the spine fracture. So that is why, and anybody who has a hip fracture, the chances of death are 25 to 50% in next 3 years. So look at the amount of morbidity and mortality associated with a hip fracture. So be very careful when we are treating that what fracture we are specially looking at prevention. Denosumab, as we discussed, is a rank ligand inhibitor. You can prefer denosumab over zoledronic acid and other bisphosphonates for various reasons. The dose is 60 milligram every 6 months. You have a more severe fracture, more severe osteoporosis, you can directly start with denosumab. No need to first start with zoledronic acid or other bisphosphonates. The fracture risk reduction again with denosumab is maximum at spine, and it is 40% at hip, and non-vertebral is 20%. Now, as I said, how you choose between zoledronic acid and denosumab? So zoledronic acid is much cheaper. A best brand of zoledronic acid would be available by 6,000 to 7,000. So it is once in a year, so 6,000 to 7,000 per year. Whereas a good quality of denosumab will be almost 20,000 per year. Annual dosing is zoledronic acid. You don't need to remember every time. Compliance will be better. Once in a year you have to give. It has some lasting effect also. Even if patient has skipped one dose for 2-3 months, the lasting effect will be still there in osteoporosis. It is less, but it is less efficacious than denosumab. It needs an IV infusion under medical supervision. Allergic reactions can happen. I had a patient who developed myositis after taking zoledronic acid injection. So there are allergic reactions. You have to tell your patient that they will have flu-like symptoms for 2-3 days after infusion. So these are the things, challenges when you give zoledronic acid, and it cannot be given in chronic kidney disease. And denosumab, on the other side, it is costly. It needs every 6 monthly dosing. Its effects are quickly reversible. So if your dosing was due in April and you forgot to tell up to June, then that 2 months bone will again start to deteriorate. But it is more efficacious, as we saw in terms of fracture risk reduction. It is easy to administer. It's like a pre-filled vaccine syringe, just like your cervical cancer vaccine. It is very easy. You can just take it. Patient can take on themselves also. Less side effects. It's a MAB. So there are no other allergic reactions. Drug holiday is not required, and it can be even given in patients with CKD. Teriparatide. 2-year treatment with teriparatide, that is parathyroid hormone, is recommended in women who are having severe osteoporosis or who had a very high risk of fracture, multiple vertebral fractures, or likely to have more vertebral fractures. So these are the cases where you use teriparatide. So teriparatide is more spine friendly, and it has a high edge over bisphosphonate when we are choosing for spine fracture prevention. So it can also be used in patients who develop fractures on bisphosphonate therapy, like your patient is taking regular bisphosphonate and still had a fracture. You can give them teriparatide alongside bisphosphonates. You can also give it alongside denosumab in high-risk individuals, like patients on steroid, patients on rheumatoid arthritis, hypogonadal patients, POI patients. Post-fracture also teriparatide is given by orthopedicians for healing. And while the patients are on bisphosphonate holiday, teriparatide can be given. Role of calcium and vitamin D, sir has already discussed, so I will not waste time. It helps only in hip fracture reduction. It does not help anywhere in spinal fracture reduction. So if you are taking regular vitamin D, still you are liable to have spinal fractures. 30%, so if hip fractures might reduce with regular dose of vitamin D. 1,000 milligram per day of calcium and vitamin D around 400 is the minimal dose that you need to give. One thing our patients are very much worried is about the renal stones. The moment you tell them that you have to keep taking calcium, they will immediately say that, what if I develop renal stone? So renal stones are likely to develop only if your calcium intake exceeds 2,000 milligram per day. And the total calcium intake should include dietary as well as supplemental calcium. So if we talk about 1,200 milligrams per day, then it is both dietary as well as supplemental. It's very difficult to calculate dietary calcium because it is very vague and we don't know how much calcium gets absorbed also. But you can tell very easily your patient that if your calcium intake is more than 2,000, only then you will develop renal stones. And if they are so worried about renal stones, you can do urine calcium create ratio because it is the best predictor of stones along with serum calcium. Vitamin D supplementation, you have 2 or 3 ways how you can do. Either you can give a regular oral supplementation, or you can give a weekly supplementation for 8 weeks and then monthly for 6 to 12 months, and then reevaluate the vitamin D deficiency. Many times I see many preparations have calcitriol. Calcitriol is indicated for very specific reasons like end-stage renal disease or hypoparathyroidism. Rest of the cases, we should give only 25-hydroxyvitamin D. Do not give calcitriol to this patient because it is very difficult to judge toxicity of calcitriol in these patients. Intake of most patients is erratic when it comes to vitamin D and very inconsistent. So ESI guidelines say that 40 to 60 nanograms per ml is the optimal vitamin D level which we should maintain to have both bone and muscle benefits of vitamin D supplementation. So these are the doses of vitamin D, minimum doses and optimal doses. And so when we talk about role of various agents in prevention of vertebral fracture, the best prevention is teriparatide. You can see in the chart. Again, when we talk about the hip fracture, the best prevention comes with your teriparatide followed by denosumab and the bisphosphonates. And this is a non-vertebral fracture, the wrist fracture and the humerus fracture, where again the best prevention comes with vitamin D, teriparatide and denosumab. So to summarize, Most important is screen for osteoporosis. That is first and very important step. Second, initiate the right drug at the right time for right duration. Anybody who has come with multiple vertebral fractures and we start with zoledronic acid is not the right thing. Hip or non-vertebral low BMD or fracture, then denosumab is the best choice. So when you are dealing with a non-vertebral fracture, first choice would be a denosumab. If you are dealing with a spinal fracture or a vertebral fracture, then teriparatide is better. So this is very important notion. I know you are not going to prescribe it most of the times, but if you have your friend, your relatives, your parents who are having osteoporosis and where you are confused, this is the rule of thumb. If you have spine osteoporosis and spine fracture, teriparatide. If hip and non-vertebral fracture, it is denosumab, followed by zoledronic, alendronate, and so on. And calcium and vitamin D, remember, is just an adjuvant treatment. It is not going to cure or treat osteoporosis. And regular BMD checkups are very important. Thank you so much. Thank you for patient hearing.
Thank you for the wonderful lecture, Dr. Rupam. Dr. Preeti ma'am, if you are there, would you like to give some concluding remarks for the lecture? Preeti ma'am, are you there?
Shatabdi, I would like to comment.
Yes, please. Yes, please.
Yeah, Dr. Rupal, you have really done justice to the talk, and thank you so much for adding so much clarity to this confusion about osteoporotic agents. And it was really enlightening which drug to use, when not to use. So thank you so much for this clarity, and really loved the example of the walls and the bricks and the cement and the plaster. It made it so clear. So thank you so much, Dr. Rupal. Thank you.
After those two wonderful lectures by Dr. Parag sir and Dr. Rupal ma'am, we would now move to a very interesting panel discussion. We have some interesting cases and we would have a case-based approach to osteoporosis, and we would like to discuss a few cases. We have the very dynamic Dr. Beenal ma'am as the moderator, along with Dr. Monica ma'am, and our experts for the panel discussion is Dr. Sneha ma'am and Dr. Sushrut sir. Can we have the CVs, please, Abhishek? Yes, Dr. Beenal.
Very brief.
Yes, ma'am. Yes, ma'am. Dr. Beenal, as we know, is the chairperson of the Public Awareness Committee of IMS. She is a consultant gynecologist and laparoscopic surgeon, and she practices at Dwarkesh, Vadodara, Gujarat. Welcome, Beenal ma'am. You are there since the beginning. Welcome once again. Our next moderator is Dr. Monica ma'am. Dr. Monica ma'am is a HOD and senior consultant at Daksh Hospital, Alwar. She is a very, very active member of the Public Awareness Committee of Fogsi. She is the West Zone coordinator of the same. She also has been the organizing president of AlwarCon. Welcome, Monica ma'am. Our experts for the session are Dr. Sneha ma'am and Dr. Sushrut sir. Sneha ma'am is the chairperson of AMOG's Medical Disorders Committee. She has been the chairperson of the Fogsi Breast Committee, and she has to her credit more than 30 years of experience and more than 300 plus talks. So we would love to have some expert comments from Sneha ma'am throughout the panel. Welcome, ma'am. Our next expert is Dr. Sushrut Babulkar sir. He is an MS in orthopedics. He is an associate professor in orthopedics at DM Medical College. He is also the president of the Trauma Society of India, as well as the vice president of NAILS. So welcome, Dr. Sushrut. We hope to have some good perspectives from your point of view for our panel discussion. We have an extravagant group of panelists over here. Our first panelist is Dr. Seema Sharma ma'am. Ma'am is the head of obstetrics and gynecology at Daffodils Artemis Hospital at Jaipur. Also, the ex-professor and head of the Department of Obs and Gynae in JNU Medical College, Jaipur, and the director of Sankalp Gynae Care. Ma'am has been the speaker for over 200 invited lectures. So welcome, Seema ma'am. Our next panelist is Dr. Rashmi Kahar. Dr. Rashmi ma'am has been the organizing secretary of AMOGS 2020. She is a consultant obs gynae at Amravati, Maharashtra. She has won the Wonder Foxian Award, and she has various awards and talks to her credit. Welcome, Rashmi ma'am.
Thank you.
Our next panelist is Dr. Chandrani. Dr. Chandrani works as a consultant gynecologist at ARC International Fertility and Research Center. She has various certificates and achievements to her credit. Welcome, Dr. Chandrani. Our next panelist is Dr. Sindhubala ma'am. Ma'am is the clinical director at Creation Fertility Center at Siliguri and senior consultant obs and gynecologist practicing in Siliguri from past almost 15 to 20 years. Welcome, Sindhubala ma'am. Our next panelist is Dr. Archana Dwivedi. Ma'am is the national chairperson of the IMS website committee. She has been the president of BOGS as well as the president and founder of MSV. And she's practicing since 20 years in Vadodara.
The bit, Monica, we can just go through.
Yeah, welcome, Archana ma'am. Our next panelist is Dr. Rashmi Banerjee ma'am. Ma'am has 25 plus years of clinical experience in practice and she is a consultant at Zydus Hospital and SG Patel Women's Hospital, Vadodara. And she's also the national chairperson of the CSR Committee of Indian Menopause Society. Welcome, Rashmi ma'am. Our next panelist is Dr. Rachna. Dr. Rachna is the vice president of TSOG as well as has been the vice president of IMA Tumkur and the chairperson of the Medical Disorders Committee Pregnancy KSOGA. Welcome, Dr. Rachna.
Thank you, ma'am.
And our last but not the least, our finest panelist for the session is Dr. Sushma. Dr. Sushma is the member of Emergency Obstetrics and Critical Care Committee at Kesoga. She is practicing in Hassan and she is the life member of Indian Red Cross Society. Welcome. She's also secretary of the Hassan Obs Gynae Society. Welcome, Dr. Sushma. I now hand over the mic to Monica ma'am and Beenal ma'am to kindly carry on with the session.
Sure. Thank you so much, Shatabdi. And I hope my screen is visible.
Yes, ma'am.
Yes, ma'am.
Making it to make it full screen, ma'am. Yeah.
Okay. So thank you so much. And I'm really happy that today IMS and Fogsi and all our women health care providers have joined hands. And it's not only the gynecologists, but the orthopedicians and the physicians, everybody together to have a brainstorming session on panel on osteoporosis. And we'll be having a case-based approach. Yes, you're very right, Parag sir, when you said that the mortality of hip fractures is very high. And there is a quote which says that we enter the world through the brim of the pelvis and frequently exit by the neck of the femur. So it is very true when we are talking about the mortality risk because of the hip fractures.
You will make it show form and it is not moving at my screen at least.
Ma'am, actually this version of Microsoft PowerPoint is older one. So we may not see it full screen.
But it is not moving also.
Okay, are the slides moving? Like I have clicked the next slide.
Yes, ma'am, but in Zoom, it will not be visible. So exit from the full screen mode.
Okay.
And click on the first slide.
Okay.
That case-based panel on osteoporosis in between.
Okay, so
and just click on the next.
Again.
Click on next. So ma'am, sorry, but this version is not compatible with the Zoom. So we can't see the full screen. You can go through like this only.
I think it will not. Can you see the screen now?
Yes, ma'am. Screen is visible, but
okay. So I'll not make it full screen.
Yes. True.
Is it comfortable to the panelist?
Yes.
No problem. Yes. Okay. Are the slides moving?
Yes, ma'am. Moving.
Okay,
yes,
fine.
ma'am. Yes.
Yeah. So as we have been discussing that from the beginning, that osteoporosis is characterized by low bone mass, microarchitectural deterioration of the bone tissue. And it was really very wonderful how Dr. Panjani explained it with the wall and the plaster and the brick theory. And we know that osteoporosis leads to increased bone fragility and increased risk of fracture. And the main problem is that why it is not getting the attention which it deserves is because it is a silent disease. And often what we see is just the tip of the iceberg, and minimal trauma can cause fracture and add to the morbidity and mortality. And yes, women are more prone to osteoporosis related fractures in their lifetime. And that is why we, being the women healthcare providers, are more responsible to kind of help her prevent this problem. 1/6 of women will have a hip fracture during her lifetime, and hip fractures are more common than the combined risk of breast, uterine, and cervical cancer. And still, all the time females are worrying more about the cancer rather than the osteoporosis. So now it deserves this attention which we are giving it right now. And yes, dear friends, we would like to discuss that are Indian women different? And I'm really proud and happy to share a study from Meeta ma'am, our own Dr. Meeta from the Indian Menopause Society, where she has mentioned in the clinical practice guidelines that osteoporosis fractures occur 10 to 20 years earlier in Indian females compared to the Caucasians. Their lower bone mass is there. Even myocardial infarction occurs earlier. Type 2 diabetes occurs earlier. And even 50% of breast cancer patients are younger than 50 years of age. So this is a really an alarming fact, and we Indian physicians have to be very alert. I would request my co-moderator, Dr. Monica ji, to please take the first case. And
Hello,
I would
everyone.
request the panelists to be very crisp and precise to the answers. Thank you.
Our first case discussion is with Dr. Seema Sharma, a 47-year-old executive, asymptomatic. After searching on internet, she came for our advice. Her last period was 1 year back and she is not having any symptoms. And next slide, please. And my first question is, what routine test will you advise in a perimenopausal or a menopausal woman? Dr. Seema Sharma.
So according to me, this patient is in the stage 2A of menopause. If we classify it according to IMS stage or Dr. Behram and Gletzeria staging. So now at this stage, she is presenting to us in a very good time when she is in a window of opportunity where we can screen her for so many things. And at the same time, she is asymptomatic, as you told. So at this time, we can have her counseled for her problems and we can have her screening. So we should go for her detail, starting from the thorough history, her family history, what type of diet she is taking. All we need to have include in our history and examination. And then we should have her weight, BMI, blood pressure, all these things done so that we can classify that is there any risk for her to be further investigated, and then we should start her workup. We should go for labs, routine investigation.
What test will you do for her?
Yeah, hemoglobin, blood sugar, these are the basic tests, liver function test, renal function test. Then some special tests also, because we can have an opportunistic screening on her for cancer, and then some special tests like mammography, bone densitometry, and if there is a family history, we can even go for colonoscopy, because these cancers do also present in later age group. And definitely FSH I will not go for, because that is not needed for the diagnosis of menopause, as we know that it is a retrospective diagnosis from 1 year of final menstrual period.
We can't go for the DEXA scan for every of the patient because it is too costly and availability is also less. So I think we can go for the high risk cases only. What do you suggest?
Yeah, actually screening should be done on the basis of screening tools like we are doing for the registry of menopausal women. We can have screening done on the basis of OSTA screening tool or FRAX tool. That is a more useful method if we screen first for the risk factors, and if there is a high risk for bone fractures, then we can go for DEXA at this stage also. Otherwise, we should have DEXA done after 5 years of menopause.
And how will you counsel her? What will you be the main? Just emphasize on the main points of counseling.
Yeah, so at this time, we can counsel her that this is a physiological event, and since she is not having any symptoms also, so we just need to screen her and counsel her about her further diet and exercise. She should have some strength exercises for muscle build-up, and diet. She should take care of all these proteinaceous diet along with calcium, vitamin D. And she should present for her examination to clinician or self-examination or self-breast examination. All these, and we should counsel her to not go for more smoking and alcohol. All these are the advices we should give her. And at the same time, we can guide her for the further symptoms of the menopause, which she can have later on, like genitourinary symptoms and some psychological irritation and all these things. We can give her an education about it, so that if she feels
So
something, she can present to us for
So most
checkup.
important, we have to emphasize on the exercise, because most of the ladies, they have the misconception about the exercise. They should have a weight bearing exercise. Just walking is not going to help. And now, what is your opinion for the prophylactic MHT on that, in this case? Just in 1 or 2 lines.
Yeah, in this case, I suppose she does not need any prophylactic MHT, because prophylactic MHT we keep reserved for the patient who are having some risk factor. If she's having such a risk factor, then we can go for it. Otherwise, we should not do a prophylactic MHT in every case. If she is having POI, menopause before 40 years, then we can give it up to the age of menopause. Otherwise, we should refrain from prescribing hormones since beginning.
Because for osteoporosis, we should start with early, because before the 10 years of the menopause, it is effective. Otherwise, after that, we have to treat it only.
Yeah, but I suppose she is not having that problem. She has not complained any symptoms. Also, if she on screening, she has fallen in a risk group for fracture, then definitely we can think of that.
Yeah, I think.
Thank you.
Yeah.
Any comment from the experts? Experts want to add something? Sneha madam, Shushruth sir.
No, I think this is good. Whatever she has
Yeah.
suggested, I think is
Yeah.
perfectly applied.
I think that's perfect. And we go ahead with the second case scenario. In the second case scenario, my question, we are taking panelist is Dr. Rashmi Kahar, madam. She's a 38 years old female who presents to you. She is in a high profile job. She has a BMI of 26. She has undergone total abdominal hysterectomy with bilateral salpingo-oophorectomy for some problem, fibroids and ovarian cyst. She doesn't have a file to give you the details. 6 months back. And at present, her complaints is of severe hot flushes since 1 month. And clinically, there is no other abnormality detected. So what is exactly the concern in this case, and how will you manage this case?
Thank you so much, Binal ma'am. Binal ma'am, my patient is very young. She's only 38 years old and she has a high profile job. I guess she must be into a sedentary lifestyle. And with BMI of 26 and such a premature ovarian failure, we can say early surgical menopause, and with symptoms of hot flushes, I think she's at the risk of early bone mass loss. So I think that is the main concern in my patient, and I'm afraid she might have early bone mass loss, and what can be done to prevent it in my patient. That will be my primary concern.
Okay. So what exactly you are considering? Treatment?
Ma'am, as we all know that because she's young and has surgical menopause, she's a very apt candidate for menopausal hormone therapy, because as we know, as per the timing hypothesis, we can have a very good window of opportunity for this patient and start her with menopausal hormone therapy.
So how this therapy can help her specifically because she is less than 40 years of age and she has got an early surgical menopause? So how exactly the hormone therapy is going to help her?
In a young patient, as we all know, ma'am, estrogen for short duration and concentrated doses is going to have a more beneficial effect than started late. Not only that, it will prevent her from bone mass loss, but it will also have beneficial effect on cardiovascular elements and various type of malignancies also, like colorectal or lung malignancy.
Yeah. So overall, it will reduce the all-cause mortality. And you are very right, Dr. Rashmi, when you were talking about the window of opportunity. So can you just explain, below 50, 50 to 60, what is the recommendation about MHT?
As in younger age groups of the patient, the beneficial effects of hormonal therapy are going to be great. Later on, as the age advances, the beneficial effects of menopausal hormone therapy started late are going to get decreased.
Right. Yeah, so you're right. So we have to see whether the benefit it outweighs the risk, and then only we are, okay in recommending this treatment. And we have to be very strictly advising our patient that it is strictly to be under vigilance and under observation. Like she cannot just continue with the self medication and without any supervision. And Dr. Rashmi, till which age will you continue this hormone therapy?
In my young patient, I will continue up to her natural age of menopause. And then I will ask the patient to review, then re-examine her, reassess her, talk with her, have opinions, and then I will decide if I can continue.
Wonderful. So thank you so much, Dr. Rashmi. Very comprehensive answers. Over to you, Dr. Monica, for the third case.
Thank you, ma'am.
It is for Dr. Chandrani Saha, a 65 years old woman came to the clinic with a complaint of back pain for 3 months. And what will be your points in history taking when you are screening for the risk factors? Dr. Chandrani.
Yeah, good evening, ma'am. As this patient is 65 years old and she had a complaints of pain, so always in my mind, osteoporosis, it will come. So for osteoporosis, there is a few risk factors are there to know about that patient is prone to for going for osteoporosis. So some certain history is there. Is there any history of fragile fracture in previous? And as she is advances, that is a positive risk factor. And definitely she achieved menopause. That is also a positive risk factor for the patient. And additionally, she is I will ask about her calcium intake. And if she had any endocrinological disorder, what are the causes for the secondary osteoporosis, like parathyroidism, hyperthyroidism, Cushing syndrome, all kind of problem. And is there any history of taking chronic, any kind of drug history like glucocorticoid therapy? All this kind of history I will ask to know to assess is there any risk factor for this patient. After that, I will take decision regarding management
Most
of this.
importantly, we have to ask what was her age for menopause, whether she was having a premature ovarian failure or she was having the menopause early or what, because these things are also going to be very important for us.
Yes, ma'am.
And drug history is also very important, and some diseases are also important. And many a times, osteoporosis is a silent disease. Only when it is a fracture, then only we can diagnose. And now what signs you will look for? Now that you have taken the history, and now in what examination, what is the important one? You just enumerate the important points.
Usually examination first, we have to see her balance and gait has been impaired or not. Second is that there is some test is there. I can tell her to stand up without holding the chair's arm. Means if she is able to perform this test, means her muscle weakness is not there. Risk of fragile fracture will be less. And we have to examine her the height. If it is height is 4 centimeter is reduced from her previous height, this is a definite positive sign for the osteoporosis. And some test is there. Is there any chest deformity or kyphosis is there or not? We can check and we can take decision. And few tests are there, occiput and wall test that if she able to touch her occiput to the wall, that means there is no signs of fracture or no signs of thoracic fracture. If she is not able to touch to the wall, there is a risk of thoracic fracture. And another one test is there, forefinger, if we able to put in between lower rib and anterior superior iliac crest, that if we are not able to put, there is a risk of lumbar fracture. All this kind of examination and tests are there to rule out that patient is developing for osteoporosis or not.
So most important is measuring the height. If there is a decrease in height, we can definitely diagnose that she is having some problem. Experts want to add something?
Yes, can I quickly suggest something?
Yes,
we as orthopedic surgeons, we tend to feel the spine. Usually thoracolumbar junction is the critical zone. There will be vague tenderness with a pinpointed tenderness that will direct us towards compression fracture. That's number one, clinically. Number two, we should take an X-ray. Digital X-rays are almost misleading because they will tend to show more of trabecular pattern, but at least they will point towards any wedge or compression fracture or not. We should consider doing a BMD and then take it further.
For all cases, sir?
So if there is a compression fracture, we want to take BMD as a milestone because we want to see at improvement in BMD 2 years or 3 years down the line. So if there is a fracture, BMD is a must. Though fracture means severe osteoporosis classification and you have to start the treatment, but for academic reasons as well as to compare, we should take BMD. We should do it.
Okay.
Thank you so much, sir.
When the 50% of the bone loss is there, only we can find the osteoporosis in the X-rays. Otherwise, in the X-ray, we won't able to diagnose the osteoporosis. I think so.
Correct.
No, Monica ma'am, he highlighted a very nice point. The digital X-ray should not be done when we. That is the punchline behind that.
Thank you so much, sir, Dr. Shishrit, for your clinical inputs. And now we come to the case 4 scenario. Here we have panelists as Dr. Archana Dwivedi, a close friend of mine from Vadodara. Dr. Archana, 48 years old woman, I mean, I'll say young women, comes to you with hot flushes. She had menopause since last 4 years, and she's asymptomatic except for the hot flushes. And she's lean, her BMI is just 18, and she has a sister who has a history of hip fracture at the age of 54. So what are the concerns for this lady?
See, Binal, this is a case where I need to put my whole antennas open because she is 48, having a menopause at the age of 44. That is the early age. She has got a low BMI, history of fracture in the family that is close related. And this is the one which is going to indicate that opportunistic screening is the best thing what we can do about this patient. So, and we also need to have the history of if she rheumatoid arthritis, smoking or alcohol consumption, which is very important.
Great. So that has been spoken. So now in this patient, would you like to use some scoring system to see that what is her risk for fracture?
Yeah, definitely. She stands above all the previous cases which we have discussed because this is where we require. There a whole basket of screening is available. OSTA score is something which is very user-friendly or doctor-friendly type of a screening system. But considering only 2 parameters, probably FRAX is a better option for this lady, predicting her 10 years probability of having a hip fracture. And score system is also very nice, which is a very simple and available online apps which can be used. But I think in this case, DEXA scan gold standard and FRAX would be a good computerized screening tool for.
Yeah, so FRAX can help you to evaluate the 10-year probability, and it is country specific. And it integrates the BMD. But in case in low resource setting, if you cannot do the BMD, that only FRAX would be also helpful. So you are right, Dr. Archana. In this patient, we had taken, we had done the scoring system, and obviously she was at high risk. And here is some scenario where, thin patients are at more risk. Yes. Otherwise, in every other problem, obesity is a major risk factor. But in osteoporosis, low BMI is a risk factor. And this is about the OSTA, that these are the limitations of OSTA, that it doesn't take into consideration the family history, previous history, use of drugs, BMD, anything. And even if the report comes about how you have to score OSTA is weight minus age multiplied by 0.2. So that is how you get the OSTA. But you are right that FRAX gives a more comprehensive idea about the scenario. In this case, yes, you are right. The BMD was done and the T score came out to be -2. So Dr. Archana, how would you interpret this? Can you explain, what is osteopenia, porosis, and how it increases the risk?
See, as Dr. Sudha Madam rightly said, that -2 is something, the cutoff which we should consider, where the window of opportunity is lost and we have to treat the osteoporosis. Above that, the score between -1 to -2 is a good window of opportunity where the osteopenia can be treated. And above -4 is the severe osteoporosis, where we have to take a Dr. Sushruta and somebody from the endocrinologist would be able to help us to treat this patient in a better way with the neuromodalities which are available.
Right.
So that's something here I would also like to say that talking about the bone mineral density, if you do a DEXA scan in this patient, even if it comes normal, repeat it every 2 yearly, so that because of our high probability of having a fracture index.
Right. So how are you going to manage this patient?
Beenal, this patient is a very, my predicting itself that she's suffering from hot flushes, plus having a osteoporosis history in the family. So I think Tibolone would be a good choice to me. But since she's 48 years and 4 years of menopause, MHT can be offered as a low budget this thing, which is going to give a better probability of having saving other complications as well. Thinking about her age factor. And we need to do something about the calcium and vitamin supplementation, which as adjuvants we have already been given, and daily dietary allowance is what she has to be prescribed. And lifestyle modification is a good truth for everybody, so I will not highlight it much over here.
Right. So how exactly is this estrogen going to help?
Yeah,
how estrogen is going to help with the bone?
That is what I was saying, that MHT or the estrogen alone, if the hysterectomized patient and combined with progesterone, because this is going to have a decrease of bone resorption, osteoclastic activities is being regulated by decreasing the production of the osteoclast. So basically the remodeling of the bone is on the more positive side. So balance of the bone mineral density tends to recover more easier when the estrogen component is there. At least if she would have been given this MHT therapy, say at the age of 44, when she had an onset of menopause, probably we would have been a better results by now.
She should have come to you earlier, Dr. Archana. You're very right. And yes, Tibolone you mentioned in the very beginning that another option for this lady, because she is more than 1 year postmenopausal, we can even consider Tibolone. But because she has hot flushes as well, MHT would be a better alternative, taking care of the entire. So would you give her sequential, or like what's your choice in this?
Like she's just 48 years, so 1/10 sequential should be a good. If she would have come earlier to me, maybe 2/10 sequential.
Right. And she says that, Madam, ये सब दवाइयाँ बहुत महंगी हैं, so can I take OC pills? Is it okay?
Yeah, at least till she is 55, we can give her as a cost-effective treatment, but she has to be counseled that MHT cannot be compared with COCs.
Yeah,
so
she will not get the same benefit.
Same benefit, and she has to continue for some times, at least when she's coming at 48. If we can give her till 50 years also, convincing, that would be a better choice for preventing her further complications. And here I would like to mention one thing. If she would have not been suffered with hot flushes, probably raloxifene would have been also a good choice in this patient.
Right. Here I would like to have some expert opinion, Dr. Shushruth sir. So what are the guidelines on MHT for osteoporosis given by the endocrine societies and IMS guidelines? And please help us, understand it better for the clinical scenario.
I think more than jumping on straight for MHT, what I suggest is we as clinicians should also look for, in addition to osteoporosis, sarcopenia, which is a major element associated with most of these patients.
Right.
Now, it is always a osteosarcopenia which we need to assess along with BMD. And there are various screening tools which are there. A very easy questionnaire like FRAX score. Now, quick word about FRAX score. FRAX specific for India, designed by Arvind Chopra and his team from Pune. It's a terrific tool. And when the patient is waiting for getting his result of BMD, I ask my BMD people only to give me a concise report which consists of FRAX as well as BMD. So serves my purpose. That's number one hint to all of you clinicians. SARC-F screening tool, which will consider a lot of points like assessment of strength, rising from a chair, the muscle mass, the low muscle mass. We have to attack these patients as a combined osteoporosis, osteopenia, osteomalacia, and sarcopenia together.
Right.
So it's not only osteoporosis which we should target. So we as orthopedic surgeons now not only consider giving, let's say, hormone therapy or osteoporosis therapy, we also try to give them treatment for sarcopenia because of, we talk about hip fracture, but why do the patients fall? Because there is low muscle mass. The patient are not able to stand, so they fall down and they break their bones. That's number one reason. Or number two reason is suddenly they twist and turn in the bathroom. They break the bone first and then they fall down. So these are the two reasons of getting hip fracture, and mind well, we are understating the implications of hip fracture. Despite of the best of the treatment in the world, 25 to 30% people within 1 year have bad morbidity, 10% die, mortality. So that's the implication that we are looking at.
Right.
Of course, when it comes to hormone replacement therapy, I send a patient to my gynecologist colleague or endocrinologist colleague. When I decide that, okay, I'm not going to give hormone replacement therapy, then the patient comes to and stays with me.
So I think I'll take it as a take-home message that proper guidance and education to postmenopausal osteoporosis is the way to go. Thank you, sir, for that.
Yeah, thank you, Dr. Shushrit. And yes, so we conclude that MHT can be used for prevention in fractures postmenopausal females, especially who are high risk at fractures, and they should be under 60 or less than 10 years postmenopause, or in those where biphosphonates or denosumab are not appropriate, with bothersome vasomotor symptoms and hot flushes, and it is lowest effective dose should be used. And these are the Indian Menopause Society guidelines. That is the first line therapy to reduce the fracture risk. And this protection ceases after once you stop the MHT, the protective effect declines. Yeah, so we come to the case 5. Dr. Monica, over to you.
Thank you. It is for Dr. Sindhu Bala. Here we have got an old lady with osteoporosis. She was on long-term use for the steroids for her asthma problem. So now what will be your diagnosis as per for the osteoporosis?
Ma'am, I have 2 queries. What is her age and how long she's on glucocorticoid? If we do not have these 2 ideas, I might conclude that she's quite long on steroid for quite long duration.
Yeah.
Because asthma is a chronic problem. Yeah.
She is more than 60 and she has been on the steroids for more than 10 years.
Yeah, so I think she might have lost 2 significant mass of her bone, and because glucocorticoid is it inhibits osteoblastic activity. So in this case, 60 years we cannot give her hormone replacement therapy, which was the backbone of our talk and therapy. So we know that glucocorticoid is osteoclastic. It inhibits osteoblast and increases osteoclast. And not only that, it makes patient lose lots of metabolic factors. It induces diabetes, it decreases bone mass, it decreases muscle mass as well. So we must treat her with all the possible tools which we have. And bisphosphonate, as Dr. Our endocrinologist, esteemed endocrinologist, doctor has said, that we must replace her lost bone. And if prescribed, we should go for parathyroid hormone-like supplements like teriparatide supplementation at least for 18 months. Subcutaneous dose, 20 microgram daily. And not only this will be sufficient, but along with that, she should be given adequate prescription for bisphosphonate also. Among them, gelinorenic acid is the preferred mode because it has to be given only once in a year and through IV route, which hardly takes 15 minutes. So she should be replaced first with parathyroid hormone-like supplement, then consolidate with bisphosphonate. And if at all required, we should not withhold calcitonin, calcitol supplement also. But we have to take care of her other supplement like calcium supplement, regular vitamin D supplement, collagen supplement, protein supplement. And we should tell her to maintain as much exercise as she can possibly do. Taking care of, she should not fall, she should not travel in a wet area. She should be given adequate protection about the slippery surfaces.
Right. So basically, we have to look towards the patient as a whole. And, besides giving the prescription, we have to give overall advice regarding the prevention of fall and all. So that was a wonderful, comprehensive answer, Dr. Sindhu, madam.
Thank you, ma'am.
So coming to the next case scenario, Dr. Reshmi, this this patient comes to you. She's a 65 years old woman with osteoporosis and vulvovaginal atrophy. So would you give her MHT? Because, we have concluded that Dr. Archana said that osteoporosis, estrogen will do all good to osteoporosis. So why not? Let's give her estrogen.
Thank you, Pinal, for involving me in this panel discussion. Now, since she's 65 years old, according to your previously mentioned IMS guidelines, she's beyond the window of opportunity. But she also has VVA, which can only be, therefore that estrogen is the choice of drug of choice. And it has been proven by several studies that estrogen at any dose through any route is also helps in improving the BMD. So for her VVA, we would like to give her, as per the availability of choice of drugs in India, I would like to give her estrogen vaginal cream, preferably 17 beta estradiol or conjugated equine estrogen. If that is not available, estriol will also do. But additionally, since she has osteoporosis, the timing hypothesis is that if the atherosclerosis is already set in, the atherosclerotic plaques are already in place, then estrogen, systemic estrogen, that is oral estrogen, should not be given because it predisposes a woman to thrombosis, thromboembolic phenomenon. But so that is what the window of opportunities is. If before the atherosclerosis has set in, if the estrogen is given, then they're at low risk of thrombosis, number one. Number two, in case for some reason we do have to give estrogen other than the vaginal dose, then with adequate counseling, even with doing the carotid intima thickness by ultrasound, then transdermal may be given, but it will not act in VVA. Oral is out of the question unless until it's a very, very severe case.
Yeah. So, we conclude that the risks are much more than the benefits. Yeah. So, this MHT is out. So, how are you going to treat her now? Agreed about the vaginal gel. But what about osteoporosis?
So
what are you going to give?
We have this wonderful drug called bisphosphonates, which would be very safe for her if she does not have any sort of esophageal, because the one thing about bisphosphonates has been discussed quite extensively by the two speakers. So what I would like to add is the way in which bisphosphonates should be given. If alendronate oral you are giving, IV is comparatively very safe because it is supervised, given by a medical personnel. But suppose we give her oral, then it should be given, it is a single weekly dose, is preferable to a monthly dose. Like Rupal said that alendronate is better than ibandronate. Ibandronate is given monthly, alendronate is given weekly. It should be taken first thing in the morning on empty stomach with at least 250 ml of water. The patient should be sitting up or be upright. She should not be lying down. So one of the most biggest contraindication is if a patient has any sort of GI disturbances or severe gastritis, or at that time it cannot be given. Additionally, of course, she should not be calcium and vitamin D deficient because that will reduce the efficacy of bisphosphonates. And one more thing I would like to add, that at this stage of life, 65 years, VVA and osteoporosis, psychological counseling does play a big role. And studies have shown that bisphosphonates do help in elevate. It has, partially a mood elevating. So giving her a positive outlook to life and encouraging her to exercise, just go out in fresh air in the morning, devoid of all her stress at home. By that time, it is an empty nest syndrome, or probably she has retired from, she was working, some financial crisis also would be there. So giving her a positive outlook to life, would also help elevate her this thing. So exercise and lifestyle changes, dietary modifications will also add. And like I said, that of course, long-term bisphosphonates which causes osteonecrosis of the jaw. So dental care she should be undergoing regular dental checkup, brushing her teeth and all that. If she needs to undergo any dental procedures, it should be given before the bisphosphonates, this thing starts. And like I mentioned, the risk of bisphosphonates, the hypocalcemia is known, so calcium vitamin deficiency should be corrected. Esophageal strictures, she should not have any form of GI this thing. Then fracture shaft femur is also known. That is a very atypical fractures of the shaft. That is for long-term therapy when you don't take a drug holiday. And of course, it is not safe for renal and hepatic, those who have renal and hepatic diseases. So I think these things have already been covered in the previous lectures.
So it was just kind of summarizing what Dr. Rupal had already told about the osteoporotic agents. And thank you, Dr. Reshmi. You're really a very kind doctor, adding a new perspective to life and, ending it on an optimistic note. So, I mean, you're very right that, we should have that human touch. We should not become just robots and write the medicines, but we should give her.
Because usually when they come at 65, they feel that having vulvovaginal atrophy and all that, it's really, really bothersome symptoms.
Yeah. So that tender loving care is really what she requires. Yeah. So thank you, Dr. Reshmi.
One more thing, adequate hydration. And on bisphosphonates, adequate hydration is very important. The patient should hydrate herself well.
You're very right. Thank you so much, Dr. Reshmi. And over to Dr. Monica for the case 7.
We have got this case with Dr. Sonia Malik, a 67-year-old lady, which was diagnosed with osteoporosis on DEXA. She's having CKD. And now we have to manage the osteoporosis. The general practitioner has started with calcium and vitamin D3. So my first question is the treatment started by general practitioner is correct or not? Dr. Sonia?
Hello.
Huh.
Yeah, can you hear me? I'm sorry, I'm in a car, so I can't be so nicely audible. So we heard the patient has CKD. So what we have to be careful in a patient osteoporosis is that the patient, it's difficult to diagnose osteoporosis and renal osteodystrophy. So the patients were with CKD might initially.
And the general practitioner has started with vitamin D3. So whether you will continue.
So vitamin D3, so we have to be careful if in case the patient's CKD status is that it's less than 30 ml per hour, the GFR, then yes, vitamin D3, we have to be careful because calcitriol is the drug of choice and this, along with the calcium citrate rather than the D3 because the conversion to D2 will be difficult with the CKD. And with CKD, the thing is, it's only the diagnosis is difficult. But on the other hand, we have to be, if the GFR is more than 30 ml per hour, then all the drugs can be used, even including the bisphosphonates. But if it is less than 35 ml per hour, then we have to be careful giving bisphosphonates. We can give the rest of the drugs, but with the bisphosphonates, there's a restriction with if the GFR is less than 30 ml per hour.
Because they are all secreted by the kidney. So we are not going to damage the kidney more. And so what will be your choice of treatment? What drugs you choose?
So choice of treatment, I think, considering over here that we really don't require an anabolic agent, denosumab is a great drug of choice in this case.
So you will give the denosumab to her. Any other?
Yeah. So the rest of the things will be the anabolic things over here. I would rather prefer denosumab over the anabolic agents.
Because it depends on how much osteoporosis she is having on DEXA. Because we have to give anabolic also and we have to give anti-resorptive agents also depending on the condition of the patient.
Correct. It also depends if the patient is on dialysis or not. That also depends. Because the calcium loss, how much is the calcium loss also we have to determine.
What are the new drugs coming? Can you highlight some of the new drugs?
So it is the denosumab, which is a promising one. But again, over here, we have to be careful that one, it cannot be tried for more than a year because it is a new drug. And second, we have to be careful about the cardiovascular profile. If the cardiovascular profile is, there is a derangement in the cardiovascular profile, then we will not prefer that drug.
And what is your opinion about bazidophine?
Bazidoxepine, yes. It can be tried in these cases. And but again, over here, because the patient has CKD and we have to give it with estrogens, again, we have to be thoughtful about that. Again, about the GFR. About the mainly about the GFR, yes.
Because this is a third generation SERM, which formed with the tissue selective estrogen complex, and it should be given with the conjugated equine estrogen, and it has got the anti-estrogenic effect also.
Yes.
So we are not worried. If we are giving, we are not worried for the endometrial hyperplasia.
Yeah.
Next case, Dr. Beadle.
Yeah,
to
yeah.
you.
Thank you.
Thank you. Yeah, so we come to case scenario or 8th case scenario. Here, the panelist, I would request Dr. Rachna to reply. Dr.
Yes.
Rachna, we have bedridden patients at home and in institutions who are immobile and quite often due to osteoporosis and related pain. So treating osteoporosis will definitely improve their quality of life. So what can you do about such patients who are bedridden and osteoporotic? What is your opinion on that?
Yeah, ma'am, such patients definitely will require a easily administrable drug which can take care. And I would also know why she's bedridden and what's the age of the patient definitely matters. If there is no renal compromise and if her GFR is more than 30 ml per minute, then I would definitely opt for bisphosphonate. And in that, the IV administrable one is zoledronic acid, and that can be given like if it is for prophylaxis, 5 milligram IV you give, that is only one injection you give for 2 years. If it is therapeutic, then you will be giving annually. So it is really convenient for a bedridden patient. In case if the patient has CKD, then we can opt for denosumab, which needs to be given every 6 months, 60 milligram, and it's subcutaneous, and that again is easily administrable. The other option is raloxifene for this patient.
Right. You're very right, Dr. Rachna. And I mean, what the message we want to give is that we should not just, to keep our hands up that we can't do anything for these patients. And actually, whatever we do, even these things could help her bone. And as we told that about exercise, little bit of musculoskeletal recovery, probably from a bedridden patient, at least she can be a little bit mobile and we can give her some better quality of life.
Yeah, if physiotherapy could be added,
exactly,
it would definitely help her along with these drugs to make her life better.
You're very right, Dr. Rachna, and thank you so much. And over to Dr. Monica for the next case.
Our next case is with Dr. Sushma, a 74-year-old postmenopausal woman who has the history of 3 fractures in the recent past. And now, can we help her? And what is the ideal therapy for her? What do you suggest? Dr. Sushma, are you there?
If she is not there, then Dr. Rachna, you can take the case.
Yes, ma'am. 70-year-old.
I think she was there.
She's there.
Sushma madam is back, but she has to join with her audio, ma'am. She has not joined through her audio.
Okay.
Yes, ma'am.
Dr. Sushma, please join.
We are getting a lot of disturbance.
Any other panelists can take?
I think Dr. Rachna, she was there. She can take.
Yes, ma'am. Ma'am, since she's already 74 years old, she needs something anabolic, ma'am, already with 3 fractures. So best thing would be giving her teriparatide.
Hello, can you hear me, ma'am?
Yes, now we can hear you. Dr. Sushma, you can add to that.
Now can you hear me, ma'am?
Yes. Yes, Dr. Sushma, please.
You're not audible.
Yeah. Best is, ma'am, you give anabolic treatment and then anti-resorptive treatment followed by it. So initially for 2 years, you give teriparatide for her, and then followed after 2 years, you can follow up with bisphosphonates for her. That would be best for a 74-year-old.
Right.
And
along with the physiotherapy, calcium, vitamin D3, nutrition
for
supplementation.
all the bisphosphonates that we give, ma'am, for all these drugs, serum calcium and vitamin D3 levels should be normal. We can't just blindly start these drugs. These 2 drugs should be normal. Only after we ensure that serum calcium and vitamin D3 levels are normal, then only we should start bisphosphonates or even teriparatide, because they need calcium to do the job.
Yeah, you're very right, Dr. Rachna. And as Dr. Gopal said, that we need to give it at least for 2 years, the teriparatide for the newborn formation. Like we cannot just give it for some time and stop it.
Like 6 months, you can't stop. Though it's an expensive option.
We have to advise her to prevent the falls also. Because she has got 3 fractures recently, so there must be some reason behind it. So we have to ask if she should walk with a support. She should not have some obstacle at the house. She should wear proper type of shoe wear. These all small things are also very important, I think.
Yeah, of course, ma'am.
What do you say?
Of
Right,
course, ma'am.
very
All
right.
these.
Yeah, so you're very right, Dr. Monica, that we have to look to the overall case scenario. I mean, what problems she's facing and what exactly caused those previous fractures. So you're very right. So besides the treatment, we should also look into the causative factors as well. Yeah, so thank you, Dr. Rachna and Dr. Monica. And sorry,
Thank you,
Dr.
ma'am.
Sushma, we could not.
Ma'am, I'm back now, ma'am. Actually, there was a network issue and suddenly
So you can have we can give her the last question.
Yeah, actually, yeah. So this question we can give to you, and then we'd like to have expert opinion from Dr. Sneha. So Dr. Sushma, take this question. And so she's a 54 years old post-menopausal female. She's a breast cancer survivor with an intact uterus. She's asymptomatic, but on DEXA, she's diagnosed as osteoporotic. So what will be your advice to her?
Ma'am, since she is a breast cancer survivor, she must be on chemo. We should ask for the history whether she is taking any chemotherapeutic agents, and we should advise a regular follow-up. And regularly we should do our bone densitometry and rule out that whether.
But she's already osteoporotic on DEXA. So how are you going to treat her?
I think.
Do we have Sneha madam here? Dr. Sneha Bhuyer. She's an expert and she was the previous breast committee chairperson.
No, ma'am, she left already.
Okay.
She had an emergency sometime back.
Yeah. Any other insight, Dr. Sushma?
Bazidoxifin is the drug of choice.
Yeah, so basically being a breast cancer survivor, obviously we'll not give her hormones. So yes, Dr. Rachna, your insight into it?
Yes, ma'am. See, for this SERMs, that is this raloxifene and bazidoxifin, they have estrogenic action, but they don't have action on the endometrium and the breast. So it is protective for the breast and the endometrium. Hence, they are the drug of choice in patients who are suffering from breast cancer or who are at risk for breast cancer.
Yeah. Yeah, so basically we'll have to choose from either raloxifene or bazidoxifene or denosumab.
Yeah, denosumab and
yeah, so tissue selective estrogen
complex also are the options for this patient.
Yeah, so thank you so much. And any other thing, Dr. Monica, you would like to add to this case scenario?
Just we have to give a proper counseling and proper positive support to her, because she's already a breast cancer patient, taking lots and lot of undergoing surgery, taking chemotherapy or other therapies also. She's all the time depressed. So we have to give a positivity. And for the osteoporosis, we have to treat definitely, because she won't have some other problems later on, because she's already into a very bad shape.
Right. So we can definitely make a change. So thank you, the panelists, and thank you, my co-moderator, Dr. Monica ji, because together we could, do quite a substantial discussion about real case scenarios and, come to some practical tips and come to some really great conclusions and take-home messages. So the key messages today are that osteoporosis represents an important cause of mortality, morbidity with onset in midlife. So when we are talking about midlife management and health, this is probably a topic which deserves a lot of attention. DEXA remains the gold standard for diagnosis. FRAX can be used even where DEXA is not available. Screening for osteoporosis should be universal post 65 years of age group and earlier in selected cases like premature menopause and all. Role of calcium and vitamin D in maintaining the integrity and strength of our bones along with exercise has to be stressed more. And here we are talking about weight-bearing exercise and resistance exercise, and not only just walking. Hormone therapy in females who are less than 10 years into menopause without any risk factors for menopause can be given and should be given. Because we are afraid or skeptical about giving hormone therapy should not be a reason that the females suffer that loss. We should not deny them that right to have the hormone therapy in the right dose at the right time if they can make a lot of difference to their life. Tibolone, bazidoxifene can be given in postmenopausal females with a uterus and with vasomotor symptoms. Raloxifene in similar cases, but with no vasomotor symptoms. Bisphosphonates are the mainstay of treatment for all 10 years post-menopause. And in glucocorticoid-induced osteoporosis and CKD patients, teriparatide, denosumab, and calcitriol should be given. Here, vitamin D3 cannot be given because D3 will not be converted into D2 in patients of CKD. So we have to give the synthetic analog, which is the calcitriol. And there is no role of calcitonin in osteoporosis in the modern days. So dear friends, it is never too early to start prevention of osteoporosis, and it is never too late to start treatment of osteoporosis. So update I hope this webinar has brought a lot of insight and updated about the latest technology and latest medical advances we have in the field of osteoporosis. We also have specialists like endocrinologists, orthopedic doctors. So the patient should not be denied the advantage of getting multi-treatment, the opinion from all, and it should be a comprehensive approach. The National Osteoporosis Foundation advocates initiating the therapy to prevent risk of fractures in postmenopausal females with the T-scores below -2 in absence of risk factors. And if there is risk factor, then start the treatment early. So let us all inspire to be like this Delhi's Dadi, who at 90 also is an athlete and getting so many medals. So thank you so much. Remember, prevention is the key. And it was really wonderful having you all learned panelists. And I thank the Indian Menopause Society and the Fogsi to come together and give us this opportunity for sharing this platform. So thank you so much. Thank you, Monica ji.
Thank you, ma'am, for this wonderful opportunity.
With me.
Congratulations, Dr. Beenal and Dr. Monica. You were superb. It was a wonderful moderation and so many practical and very valuable tips from the experts. It was wonderful case scenario.
Thank you.
Thank you for inviting me.
Thank you, everyone. Yeah.
Thank you for making me a part. Thank you.
Excellent. The webinar you have arranged, really. So many new points which we acquired with this webinar. Thank you. Thank you all, really.
Thank you, Ambuja ma'am.
Yeah.
Beenal has precisely given what take-home message, and I think it will be very helpful for everyone.
Thank you, Monica. Thank you, Shatabdi, and thank you, Monica Umbadand as well.
Thank you, ma'am. Thank you for this opportunity, ma'am.
Shatabdi, can you give the official vote of thanks?
Yes, Monica. Yeah. Thank you to everyone for sparing time on this evening and for this lovely discussion on osteoporosis and the medications for the preventive measures as well as the therapeutic measures. We really had some very nice crisp messages. Thank you to the Indian Menopause Society as well as Fogsi, and wish you a very good night to everyone. Thank you all.
Thank you, Corona Remedies, for an academic platform. Thank you, Beenal ma'am, for all your inputs for the execution of this webinar. I would also like to thank all the judges, Pushpa ma'am and Aarti ma'am, for graciously being there for the inauguration of this webinar. Thank you so much.
Thank you. Bye.